नमस्कार, गुड मॉर्निंग। हेल्थ फॉर ऑल के 25वें एपिसोड में आप सबका हृदय से स्वागत है। आजकल लोग तनाव में बहुत रहते हैं। घर में तनाव, बाहर तनाव, दफ्तर में तनाव, आर्थिक तनाव, सामाजिक तनाव, पढ़ाई की चिंता, नौकरी चिंता वगैरह वगैरह। लेकिन इन सब के बावजूद हम ये भूल जाते हैं कि ये सब हमें एक मानसिक रोग की तरफ ले जा रहे हैं। आमतौर पर हम मेंटल हेल्थ के प्रिवेंशन के लिए कोई ध्यान नहीं देते। शरीर में जब तक तकलीफ ना हो हम डॉक्टर के पास नहीं जाते। मेंटल हेल्थ के कई कारण होते हैं, कुछ को हम प्रिवेंट भी कर सकते हैं, तो क्यों नहीं करते हैं। इन सबको ध्यान में रखकर हमने आज के एपिसोड को का विषय रखा है मेंटल हेल्थ एंड बाइपोलर डिसऑर्डर। इस शो में आज देश भर के कई जाने माने मेंटल हेल्थ एक्सपर्ट्स में जागरूक करेंगे कि हमें अपने मानसिक स्वास्थ्य को लेकर क्यों और कैसे सतर्क रहना चाहिए। दुर्भाग्य से हम ऐसा नहीं करते हैं। हम मानसिक रोग के प्रति सतर्क नहीं रहते हैं। जब ये मर्ज बढ़ जाता है तब हमें या हमारे परिवार वालों को चिंता होती है। उम्र बढ़ने के साथ ये जानना और भी जरूरी हो जाता है कि क्या करें, क्या ना करें। हमारा ये शो अगले 3 घंटे तक यूट्यूब और फेसबुक पर लाइव रहेगा। तो हमेशा की तरह सबसे पहले देखते हैं ये राउंड अप वीडियो। हमें नमस्कार, हेल्थ फॉर ऑल में आप सबका स्वागत है। 24 मार्च वर्ल्ड टीबी डे के रूप में मनाया गया। दुनिया भर में काफी गहमागहमी रही, लेकिन भारत में ये केवल औपचारिकता नहीं रही। यहाँ इस बात पर ज्यादा चिंता व्यक्त की गई कि सरकार ने टीबी इरेडिकेशन का जो लक्ष्य 2025 वर्ष रखा है, क्या हम उसमें कामयाब होंगे। सरकार की ही एक रिपोर्ट के अनुसार पिछले साल टीबी के मरीजों की संख्या 19% बढ़ गई। ऊपर से कोविड महामारी ने टीबी इरेडिकेशन कार्यक्रम पर भी बुरा असर डाला है। आखिर क्यों अनियंत्रित है भारत में टीबी रोग? क्या हम 2025 के लक्ष्य को पूरा कर पाएंगे? क्या नया हो रहा है इस क्षेत्र में? ऐसे कई सवाल हमारे आपके मन में उठते रहते हैं। आज हम उन्हीं सवालों के जवाब जानने की कोशिश करेंगे देश के जाने माने विशेषज्ञों से। और अब वक्त है योगा सेशन का।
ट्यूबरकुलोसिस बहुत सारी जगह होता है, लाइक टीबी मेनिंजाइटिस होता है, ब्रेन का टीबी हो सकता है या लिवर का टीबी हो सकता है। बट योगा का रोल सिर्फ 2 टीबी में आता है और वो है पल्मोनरी ट्यूबरकुलोसिस, जिसमें आपका लंग्स इन्वॉल्व होता है। एंड वो भी 2 टाइप का होता है, एक्टिव ट्यूबरकुलोसिस और लेटेंट ट्यूबरकुलोसिस। एक्टिव में क्या होता है कि आप अभी भी इन्फेक्शियस है, तो आप कफ करेंगे या स्नीज करेंगे या कुछ भी ऐसा करेंगे तो दूसरे को भी फैल सकता है। तो इफ यू आर एन एक्टिव केस ऑफ ट्यूबरकुलोसिस, देन यू शुड मेक श्योर दैट you are doing any kind of pranayam only in a closed atmosphere and not doing it outside or nearby any person, because you can give tuberculosis. Latent tuberculosis, yes, you can practice these pranayam. The second place where physiotherapy or yoga helps is in spinal TB. Okay, सो इनिशियली व्हेन द स्पाइन टीबी इज देयर, जब आपका एक्टिव है तो आप कुछ भी नहीं कर सकते अपार्ट फ्रॉम बेड रेस्ट, स्पेशली इफ इट कम्स टू एनी रीजन लंबार एंड सर्वाइकल, तो आपको बेसिकली रेस्ट लेना है और तब तक रेस्ट लेना है जब तक टीबी कम नहीं हो जाता। तो अगर पल्मोनरी ट्यूबरकुलोसिस है हमें, जिसमें हमें सांस लेने में प्रॉब्लम हो रही है, कफ हो रहा है, स्पूटम हो रहा है, तो 2-3 चीजें हैं जिसको हम ध्यान में रख सकते हैं। एक, कोई भी प्राणायाम जिसमें फोर्स्ड एक्सपिरेशन होता है वो हमारे लिए बहुत अच्छा है, स्पेशली फॉर ट्यूबरकुलोसिस। ओके, फोर्स्ड एक्सपिरेशन मैं बोलूं तो जैसे कि भस्त्रिका प्राणायाम। भस्त्रिका प्राणायाम आप 2 तरीके से कर सकते हैं, एक अगर आप हाथों को यूज करके और एक बिना हाथों को यूज करके। तो अगर आप बिना हाथों को यूज करते हैं तो आप बेसिकली एक गहरी लंबी सांस लेते हैं और फोर्स्ड एक्सपिरेशन करते हैं। आप देख रहे हैं यहाँ पे मैं सिर्फ और सिर्फ नेजल कैविटी का यूज कर रही हूँ, मतलब ये रीजन यूज कर रही है, एब्डोमिनल मसल्स इन्वॉल्व नहीं है। दूसरा प्राणायाम जो आप ट्यूबरकुलोसिस में कर सकते हैं वो है कपालभाति प्राणायाम। कपालभाति प्राणायाम में आप एब्डोमिनल मसल्स यूज करते हैं। एब्डोमिनल मसल्स यूज करने की वजह से आपका एक्सपिरेशन और स्ट्रॉन्ग होता है। तो आप नॉर्मल इंस्पिरेशन लेते हैं और फोर्स्ड एक्सपिरेशन, नॉर्मल इंस्पिरेशन, फोर्स्ड एक्सपिरेशन, नॉर्मल इंस्पिरेशन, फोर्स्ड एक्सपिरेशन। तो जब आप इसको एक रेगुलर इंटरवल पे करते हैं तो कुछ ऐसा दिखता है।
और अब वक्त है गांधीगिरी का। आप सोच रहे होंगे हेल्थ फॉर ऑल में गांधीगिरी, आपने फिल्म लगे रहो मुन्ना भाई में हीरो को गांधीगिरी करते देखा होगा। गांधीगिरी मतलब नेगेटिविटी को पॉजिटिविटी में बदलना, बुराई को अच्छाई से जीतना, ये एक कला है जिसे गांधीगिरी का नाम दिया गया। आज हमारे शो में एक डॉक्टर की नजर से देखेंगे गांधीगिरी। तो हम स्वागत करते हैं डॉक्टर वीरेंद्र सिंह का अपने सेगमेंट योर हेल्थ काउंटर में। डॉक्टर वीरेंद्र सिंह महावीर जयपुरिया राजस्थान हॉस्पिटल के प्रेसिडेंट हैं। वह रेस्पिरेटरी और चेस्ट के पायनियर डॉक्टर्स में से एक हैं। अपने 40 साल के अनुभव में उन्होंने हेल्थ केयर सेक्टर को बड़ा योगदान दिया है। इनमें पिंक सिटी फ्लोमीटर और पिंक सिटी लंग एक्सरसाइजर शामिल है। ये दमा के मरीजों के लिए काफी उपयोगी है। डॉक्टर वीरेंद्र सिंह को मेडिकल क्षेत्र का सर्वश्रेष्ठ सम्मान डॉक्टर बीसी राय अवार्ड से नवाजा गया है। डॉक्टर सिंह फिलहाल एसएमएस मेडिकल कॉलेज के सुपरिटेंडेंट के पद से रिटायर होने के बाद जयपुर के आसमा भवन में डायरेक्टर के रूप में सेवा दे रहे हैं।
As we have witnessed how unprecedented COVID-19 pandemic has wreaked havoc, challenging the Indian healthcare ecosystem. So, do you think that the Indian healthcare ecosystem is also required to follow Gandhigiri as truth is its guiding force?
कोविड जब आया तो मैं कार चला के जा रहा था मेरे हॉस्पिटल, राजस्थान हॉस्पिटल। उस टाइम लॉकडाउन लगा हुआ था, कार बिल्कुल सुनसान सड़क पे इकलौती मैं चला के ड्राइव करके ले जा रहा था। मुझे ऐसा एहसास हुआ जैसे एक सैनिक एक युद्ध में जा रहा हो। और वहां जाके मैंने पूछा अपने जो नर्सिंग स्टाफ एंड सबऑर्डिनेट डॉक्टर से, क्या आपको भी लगा? बोले हाँ सर लगा। तो मेरी एज उस टाइम 67 थी। तो सब घर वाले सब कह रहे थे भाई आप पेशेंट देखना बंद करो। मैंने कहा नहीं आप पेशेंट देखना कैसे बंद करेंगे, ये तो एक सैनिक के कर्तव्य का सवाल है। तो जब वो पेशेंट्स देखा तो उस टाइम एक घटना जो मतलब आप ये देखिए कि वो जितने महीने चला कोविड, कोई दिन ऐसा नहीं था जब आंखें आंसू से नहीं भरी। इससे एक बात और है, उस टाइम तो आक्रोश था लेकिन आज पब्लिक में आक्रोश कम है। एक हमारे फ्रेंड अभी उदयपुर कॉन्फ्रेंस में आए थे, उनकी गाड़ी खराब होगी, रास्ते में उनको लिफ्ट दी किसी ने और उन्होंने कहा कि आप साहब उनको मुझे कॉन्फ्रेंस में छोड़ दो। उन्होंने 3 किलोमीटर उदयपुर से दूर स्थल कॉन्फ्रेंस जगह छोड़ा और पता है क्या कहते हैं वो पैसे देने लगे उन्हें। वो बोले साहब आप ही डॉक्टर्स ने हमारे प्राण बचाए कोविड के अंदर, आप फीस की, आप जाने की, ट्रेवल की बात ही क्या करते हो साहब। तो ये मानसिक स्थिति इस समय पूरी पब्लिक की है पोस्ट कोविड के अंदर, और इसमें जरूरत हम डॉक्टर्स को थोड़ा सा, यदि हम अपनी लक्ष्मण रेखा खींचकर इस सहृदयता को अपने दिल से लगा के यदि करेंगे तो निश्चित तौर से इंडिया में बदलाव संभव है। कुछ गांधीगिरी, कुछ दिल से, दिमाग के साथ साथ दिल से भी यदि हम काम लेंगे तो निश्चित तौर से ये जो वायलेंस, ये जो एजिटेशन, इसको हम निश्चित तौर से खत्म कर सकते हैं।
एज पर गवर्नमेंट प्लान 2025 तक टीबी को कंप्लीटली इरेडिकेट कर देना है इंडिया में, ये प्लान है। आज क्या स्टेटस है, हम कहाँ हैं, क्या ये संभव है?
आज हम देख रहे हैं कि पिछले कई सालों से इस बात पे बहुत चर्चा हो रही है कि 2025 के लिए जो हमारे प्रधानमंत्री जी ने एक बीड़ा उठाया है टीबी एंड करने के लिए, है कि नहीं। और हम सब कहीं ना कहीं ये जानते हैं कि अभी के जो फिगर्स है उससे तो कोई उम्मीद बहुत ज़्यादा नज़र नहीं आ रही, और इसके ऊपर हमने बहुत सारी चर्चा भी कर ली, बहुत सारी एनर्जी भी डाली है। और ये जो पैंडेमिक हुआ उसमें और भी ये फिगर्स थोड़े डिस्टर्बिंग ही है। जैसे 41% हमारा नोटिफिकेशन कम हुआ, वर्ल्ड में सबसे ज़्यादा नोटिफिकेशन जो कोई कंट्री में कम हुआ तो वो इंडिया में है। टीबी की मॉर्टेलिटी भी बढ़ी है, टीबी का इंसिडेंस भी बढ़ा है। पर मुझे अब ये लगता है कि ये विषय पे काफ़ी चर्चा हो चुकी है और हमने काफ़ी हमारी एनर्जी डाली है ये डिस्कस करने में वेदर इट इज़ पॉसिबल और नो। बट मुझे ऐसे पर्सनली लग रहा है कि हमें अब थोड़ा अलग तरीके से सोचने की ज़रूरत है।
What is your view on the challenges associated with making universal lung health care a reality, and how innovation can help infrastructure or catalytic funding? So can you please specifically talk about it with relevance to India? Because I also came across a lot of programs where you brought in technology, innovations, and a lot of other things.
So basically, as I initiated my discussion, we would like to be a very, very strong force to be reckoned on. Basically, we want to be a public-private partnership, excellent partner for government, where we have initiated certain initiatives. Maybe Dr. Vikas is here. So we have done initiative with the organization like Union, where, as all of you were talking about corporate hospital openings, why patient is not getting treatment in corporate hospital across India. So I think this was well guided by Dr. Vikas, and we have taken up this initiative with the Union, and we will be taking it to a new direction. So coming to challenges part is like, I personally believe, I think a quick decision making across our organization, across public health side is very, very important, and quick policy making on new initiatives would be very, very helpful. Though tuberculosis initiative, I personally believe it is one of the finest program, and where a lot of public engagement, a lot of private side engagement is already in place. It is the private will which matters the most than government coming forward. Government is forthcoming, and I think they have made a lot of private people as their training heads, as their national committee members. So these are the few factors I believe, and government has already moved from needle already from global fund to a domestic fund. So where now I see there was a time when 80% was used to be global fund. Now I see it is 80% we are utilizing domestic fund now.
WHO की रिपोर्ट पिछले साल की है 2021 कि कोविड पेंडेमिक के दौरान टीबी केसेस की रिपोर्टिंग में ग्लोबल डिप हुआ है, जिसका 40% लगभग सिर्फ इंडिया में हुआ है। क्या केसेस कम हुए हैं या रिपोर्टिंग कम?
2019 से पहले एक आंकड़े हैं हमारे देश के, उसमें दिखाया गया कि 27 लाख टीबी के केसेस दर्ज हुए थे, उसमें से 79,000 डेथ हुए थे एक साल में। तो अगर हम उसको तोड़ के देखें तो एक क्वार्टर में करीब 20,000 डेथ हुई। और कोविड काल में जब महामारी कोविड की फैली हुई थी, जब 2019 से आगे, उसमें एवरेजली एक क्वार्टर में करीब 15,000 डेथ हुई। तो देखा जाए कि 20,000 और 15,000 को कंपेयर करें, जबकि कोविड काल में जो महामारी आई उससे ज्यादा महामारी हमारी पहले से ही आ रही है। तो एक बहुत बड़ी आपत्ति की ये संकेत है। तो ऐसा नहीं है कि कोविड काल में जो डिटेक्शन डेफिनेटली कम हुई है, क्योंकि हेल्थ केयर सेक्टर सारे कोलैप्स कर चुके थे। और सबसे बड़ी बात जो थी हमारी सरकार के अंदर, जो 90% जो गरीब लोग जो डायरेक्टली ऑब्जर्व थेरेपी डॉट्स प्रोग्राम में जाते थे, वो सुविधा थी नहीं, क्योंकि पूरा सेक्टर ही कोलैप्स पड़ा हुआ था। तो रजिस्ट्रेशन नहीं हुए, डिटेक्शन नहीं हुए हैं, डेफिनेटली उनको दवाई भी नहीं मिल पाई। तो गरीबों को तो बहुत घाटा होता है। और दूसरी बात, कुछ प्राइवेट आंकड़े भी बता रहे हैं कि उस समय कोविड काल में करीब 38 से 40% ट्यूबरक्लोसिस बढ़े भी है उस समय। तो डेफिनेटली कोविड काल के कारण मैकेनिज्म फेलियर होने के कारण, और एट द सेम टाइम जो पहले की अगर आंकड़े देखे उसको भी अगर दिमाग में रखते हुए देखिए, तो हम ये कह सकते हैं कि जब आंकड़े हमारे पास थे तब भी क्वार्टर में डेथ 20,000 हो रहे थे। तो अगर आप कोविड के 3 साल के भी हम आंकड़े को अगर 15-20% अगर जोड़ ले, तो डेफिनेटली ये एक महामारी के रूप में ये ट्यूबरक्लोसिस हमारे देश में फैलता जा रहा है।
So what is your view on where the real impetus has to be in the public-private partnership in eradicating TB?
Now the time has come where it is next to impossible for a alone sector to think that he can eradicate TB. It is next to impossible. Only private sector cannot handle TB 100%. If only public sector thinks that they will take care of this tuberculosis and eradicate from India, it is next to impossible again. And even NGO. So we will need help of each and every sector sitting in the field who is working or having a intention of joining hands for fighting against TB. Unless until all these sectors come together under one single roof and work for a single goal, it is going to be next to impossible to win this battle against TB. ये तो बहुत sure है. Like private sector don't have time, or rather they have many other diseases also to take care of. They don't have manpower with them. Okay. Second, public sector are too busy. They have lot many diseases under their umbrella to take care of, and not only tuberculosis. And NGOs, they are the ones who are going to fill the gap between both private and public, and going to act as a bridge between both of them and create a good bonding between both of them. If private has a problem, we can approach NGO. NGO can take care of the problem and bring it in front of the public sector and just create a solution over there. So unless and until these three sectors come together and gel around together, it is going to be next to impossible.
What I have seen to and fro is a lot of changes happening in the guidelines. Any of the latest changes which you would like to highlight, which impacts the treating doctors as well as impact the patient also in the guidelines?
The government is willing to scale back the resistant tuberculosis program, which was the shorter course regimen, which is started for 9 to 11 months, which is currently ongoing in most of the cities. In the peripheral part, they are still continuing with this regimen, which is very toxic, and the failure rate is very high. The failure rate is as high up to like 65 to 70% in it. So the government is planning to scale it back, and they are wanting to shift it to a non-injectable based regimen, which is a bedaquiline based regimen.
मेरा सवाल ये है कि ये बीमारी टीबी के इरेडिकेशन में सबसे बड़ी बाधा ये है कि इसके साथ सोशल स्टिग्मा जुड़ा हुआ है। तो उस क्षेत्र में क्या काम हो रहा है?
ये बहुत बड़ा एक चैलेंज है टीबी पेशेंट के लिए। मैं आपको कुछ एग्जांपल्स देता हूँ, हम कहाँ फेस करते हैं और उसके लिए हम लोग क्या चीज़ें हम लोग पेशेंट्स को और उस टाइप से काउंसिल करते हैं। सिंपल से एग्जांपल मैं देता हूँ, अगर किसी की शादी होने वाली है और उसका डायग्नोसिस टीबी पता चलता है, तो हमारे सबसे बड़ा चैलेंज ये रहता है कि शादी के बाद में भी वो महिला या वो पुरुष अपना टीबी का इलाज कंप्लीट करे, क्योंकि अधिकतर टाइम में ये होता है कि टीबी का इलाज कहीं भी दूसरे घर में जाके सोशल स्टिग्मा इतना जुड़ा है कि बताया नहीं गया था या बताया था हमें पता नहीं था, ये सब चीज़ें आने लगती हैं। दूसरा चीज़ जो दूरी वाला होता है कि झूठा नहीं खाना, उसको बिल्कुल एक आउटकास्ट करके एक तरह से रख देते हैं। एक पेशेंट जो कि एक बीमारी से जूझ रहा है, एक पेशेंट जिसको इतनी सारी दवाइयाँ खानी है, जिसको अपने अंदर खुद ही नेगेटिव थॉट्स आ रहे हैं, उसके लिए कितना चैलेंजिंग होगा अगर उसके परिवार वाले भी उसको एक तरह से साइड में करें कि भाई तुम इस किसी को पता नहीं चले, एक तरह से छुआछूत की तरह उस दृष्टि से उसको देखा जाए, तो बहुत चैलेंज है। साइकोलॉजिकली बहुत चैलेंज हो जाता है। पेशेंट कई बार इसी उससे डिप्रेशन में भी चले जाते हैं।
Namaskar and welcome to a brand new episode of Health4All. In fact, this is the 25th episode, and I'd like to remind our viewers that we are live on Facebook and YouTube. I'm Shankar Raj, the president of Heal Foundation, and the first session is on yoga for mental peace. And we have with us Ms. Mahati Vispute. Glad to see you again, Mahati. I think it was wonderful having you in last time during the mudra session. I still remember that. And she has been a yoga enthusiast for over 10 years and later became a trainer at Yoga Darshan in Mysuru. She's also a volunteer at the Art of Living organization and takes yoga therapy at Arogya Physiotherapy Medex Hospital, Bengaluru. Over to you, Ms. Vispute, and you have time till 8:55 so that we can take a couple of questions. Okay?
Namaste. Today's topic is mental health in yoga, and absolutely no mental health conversation can get over without the mention of yoga, because just yoga is the absolute answer. Not absolute, I will say it has to be paired with many other solutions, definitely, but yoga will provide many solutions to you. Normally when we talk about yoga, we'll say for mental health, do meditation. But meditation is very difficult. It takes years of time and practice to be able to meditate well. So today we're going to be looking at various solutions and also meditation towards the end. Yeah. Now for a basic understanding, in yoga there are two types of yoga. Okay, there are multiple yoga practices which are around the world, but we're looking at yin yoga and yang yoga. Okay, yin yoga is when the yoga is calming, it is relaxing. आपको योगा करने के बाद मतलब ऐसा लग रहा है कि हाँ स्ट्रेच करा, अच्छा लग रहा है. You are refreshed. Second type of yoga is for strength, stability, flexibility. That is yang yoga. जैसे अष्टांग योगा करते हैं, that is slightly like a gym version of India. Okay, that is more extensive. Okay, so obviously for mental health, we're going to be looking at yin yoga, and those who want to practice mental health and are doing yoga for it, yin yoga is going to be the best for you. Okay. Yoga has three parts: asana, pranayama, meditation. Okay, हम asana से शुरू करने वाले हैं, सबसे आसान है, and meditation is like very difficult. It takes time to be able to meditate well. So we're going to start with asanas. Okay. First thing that we do is there are going to be three types of asanas we are catering to. Okay, first being hip opening exercises. Okay, मैं आपको एक आसना नहीं सिखाने वाली हूँ, आपको समझना है कि आप ये आसन क्यों कर रहे हैं. Okay, so because let's say I tell you one asan to do like this, और अगर आपको knee pain है तो आप नहीं कर सकते. But you have to understand why you are doing the asana, so you can do an asana which is right for you, which you are able to do. Okay, so hip opening asana for the first one. इसका सबसे बेस्ट और आसान सोल्यूशन है वॉकिंग. वॉक के लिए जाइए 10 minutes, 20 minutes, half an hour, however long that you can. It is very good for your health. Second will be in hip opening asanas, let's say you're doing side stretches or you can be doing lunges. Okay. इसी में आता है अंजनीय आसना. तो आप ये आसना कर सकते हैं जिसमें आपके हिप ओपन हो रहे हैं. काली आसना, if you're sitting down. Yeah, so all of these are going to help you open your hip. And why do we do hip? It's because Mooladhara chakra is one of the chakras. It's the first chakra in your body, which is very important. It is at the bottom. Okay, when you sit down, it is the lowest position of your body. Okay, Mooladhara chakra इसलिए होता है कि आप अगर आपने वो chakra activate करा, then you're moving towards wanting to do something. आपको ये चाहिए ना कि आपको जिंदगी में चाहिए कि आपको कुछ करना है. Okay, it moves from inertia to mobility. इसलिए अगर आपको मन नहीं कर रहा है काम करने का, you don't know what to do, you are very bored today. Okay, go for a walk. It helps very well. It is because you are activating your Mooladhara chakra when you're walking. Other solutions will be hip opening asanas that I just spoke about. Second set that we're looking at is balancing asana. कोई भी आसना जिसमें आप बैलेंस कर रहे हैं, जैसे एक पैर पे बैलेंस करा, वृक्षासना, आपने हाथ सामने जोड़ लिए, हाथ ऊपर जोड़ लिए. दिस इज वन ऑफ द इजियर बैलेंसिंग आसना. अगर आप इतना ऊपर भी नहीं कर पा रहे, यू कैन स्टैंड नियर अ वॉल, टेक सपोर्ट, जितना पैर ऊपर हो रहा है उतना, देन यू स्लोली ट्राई टू मूव योर हैंड्स अवे, जितना हो रहा है उतना, राइट? So in this also, if you're already very fit, you can try Natarajasana, Garudasana. These are slightly difficult versions, but the point is you have to balance. Now, why are you balancing? When you balance, you learn to focus in one place. It helps you focus and concentrate, which is extremely important for us. Yeah. Moving on to third, we're going to be looking at inversions. Okay, inversion क्या होता है? सर नीचे. Okay, ideally handstand, headstand, but these are very difficult. आपको बहुत दिनों की, महीनों की प्रैक्टिस लगती है इसके लिए. So very simple inversions where blood is flowing to your head will be bend down, touch your feet. Stay for some time. Yeah, otherwise you can spread your legs, bend down. All you have to do is move your head to the ground. So इसमें you can even do mountain pose when you're doing this. Even mountain pose is going to help because blood is flowing to your head. Okay, these are three very important sets in asanas that you should do if you are looking for mental health. Okay. For a recap, first one, hip opening. Second one, we looked at balancing. The first one, hip opening. Second one, balancing. Third one, inversion. They're very simple and you should find an asana which is right for you, which is easy for you to do. Now, in the start, I said we're going to do asana, pranayama, meditation. But directly shifting from asana to pranayama is also very difficult. Imagine someone telling you कि आप अनुलोम विलोम 10 मिनट करिए. It is very hard to sit down. आदत नहीं है हमें. So we're going to be looking at asana plus pranayama. जैसे आप exercise with breathing, conscious breathing आप करने वाले. So the first one is when you're standing. Okay, stand straight, back straight, body set, head straight. Interlock your fingers, breathe in, breathe out. When you breathe out, your hands are coming down. Okay, you leave your elbows loose. Okay, so breathe in and breathe out. Breathe in and breathe out. Okay. Now the second part of this is breathe in 45 degrees and breathe out. Breathe in and breathe out. The third part, breathe in and breathe out. Breathe in and breathe out. In the third one, if you can even breathe in, come on your toes, breathe out, come down. Breathe in, come on your toes, breathe out, come down. These you can do. You can maybe start with sets of 3, 3, 3, then 5, 5, 5. Keep increasing if you feel like. Now we're moving to ones where we can sit down. Give me a minute where I move the camera. Okay. Now we're looking in, again at asana plus breathing, but while sitting. You'll sit in Vajrasana. Okay. Back straight, neck straight, head straight. Next, what you'll do is you have to hold your hands behind like this. Hold one hand with the other at your wrist. पीछे हाथ पकड़िए, सामने देखिए. Breathe in. Push your head back. Roll your shoulders back. Move your chest outwards. And breathe out. When you come down, touch your head to the floor. Elbows should drop. Okay, so breathe out, come down. Breathe in. Breathe out. Breathe in. Breathe out. Ideally, you should keep your eyes closed. Yeah. So this was a second asana, wherein asana plus pranayam you are doing. Now the third one that you can look at, where you are lying down, is going to be shavasana. Okay, सभी का योगा में फेवरेट अगर कोई आसना है तो वो शवासन ही होगा. It's very simple. लेकिन not everybody who is lying down and closing their eyes is doing shavasana. Okay, shavasana में how do you say it? You say go into shavasana. Okay, you have to feel the shavasana. Okay, so there is honestly there is no way for me to explain what that feeling is. Okay, you're supposed to be lost but listening. Okay, listening to the instruction. So the best way to practice shavasana will be in the start will be to have an audio video recording or to have a trainer who is instructing you how to go into shavasana, how to be able to lose your body, observe your body. These are very important things of shavasana. You're actually supposed to do something. Okay. So we have one video on Arogya Physiotips YouTube channel. It is my video of a 10 minutes shavasana. So if you have already exercised, कोई भी योगा या फिर आप कोई और एक्सरसाइज भी कर रहे हैं, उसके बाद you can play this video and go into shavasana for about 10 minutes. That will be a good way to start. Later, you can do shavasana on your own once you have practiced. Now, these asanas and asana plus pranayam, which I spoke about, ये नहीं है कि वो मुझे मेंटल हेल्थ का थोड़ा इशू लग रहा है, मुझे लगता है बहुत स्ट्रेस है, मुझे लग रहा है बहुत टेंशन है. That is why I will specifically do these. No, these have to become a part of your everyday exercise. तो अगर आप हर रोज योगा कर रहे हैं या फिर हर रोज कोई भी एक्सरसाइज कर रहे हैं, in the middle you can practice one of these breathing plus asana exercise, or you can make sure you include, in the start I told 3 types of asanas. You should include one of each type. Okay, honestly, क्या होता है कि अगर मैं आपको सिखाने जाऊं कि वृक्षासन कैसे करते हैं ऑनलाइन, या फिर अभी सभी के पास इतनी सुविधाएं हैं, so many yoga trainers also around the world, that you can learn from them, but what you need to understand is why you are doing it. अगर आपको समझ में आ जाए कि क्यों कर रहे हैं, then you can choose the right asana for you. Like I had told you in the start, if I teach you one asana, और जैसे मैंने कहा कि इस आसना में हाथ ऊपर उठाना है, but let's say you have a frozen shoulder, आप तो कर ही नहीं पाएंगे, but there are always alternatives. So you should learn why you're lifting your hand up. Okay, so we are done with asana plus pranayama. Now we can move on to the next set, which is going to be pranayama. Now pranayama is a very when I say asana, pranayama, meditation, it's a way to move towards meditation. When you learn to exercise, then you learn to exercise and breathe with it. You learn to breathe correctly, and then you learn to meditate. So in breathing exercises also, it is very important to start slowly. So we're going to first learn how to breathe slowly. Okay, काफी in these few minutes, it is not possible to actually correctly learn, but at least you should know if you're doing something right or wrong. Yeah? So if you're sitting, ideally you'll be sitting. You will have a mudra which you can choose. Now, I've taken a session of mudra from the last session, but for today I will teach 2 mudras. Okay, पहला mudra, which is the mother of all mudras, mental health के लिए भी best, Jnana mudra. Okay, you have to touch the tips of your index and thumb. Leave the other fingers open. It has to look towards the sky. Place them on your knee and sit. Okay, ये ज्ञान मुद्रा सभी के लिए अच्छा है, मेंटल हेल्थ के लिए बेस्ट है. It helps you focus, concentrate. It's what I will suggest. Okay. Now there is one more mudra which I hadn't taught the last time, but it is really good. Okay, for anybody who is a decision maker, for anybody who is learning or who is teaching. Okay, आप उस लाइफ के फेज में हो जहाँ पे आपको बहुत सीखना है, या फिर आप वहां पे हो जहाँ पे आप खुद बहुत डिसीजंस ले रहे हैं. So this asana will help you focus, to concentrate, to make the right decision. Okay, you're looking at Uttara Bodhi asana. Okay, you have to interlock these 3 fingers, touch the front of index, touch the front of your thumb, ऐसे. Okay. Now in this asana, in this mudra, you will always place it such that the index finger is pointing up, hamesha. Okay. So index finger pointing up, Uttara Bodhi mudra, आप बैठे हुए. Okay. It is a very nice mudra if you are learning. I just told you, right? So do this mudra, you sit down, close your eyes and sit. Sit for 5 minutes, sit for 10 minutes. Yeah, you just have to sit down. Now, on how a mudra works and why this is good is from previous sessions. I will not focus on that today. We are learning breathing exercises right now. Okay, that is why I told you these 2 mudras. So in breathing exercises, you will first start with, let's say, you're taking Jnana mudra, sitting down. You can even be sitting in Padmasana or Ardha Padmasana, whichever is comfortable for you. Okay, but anywhere where you are sitting cross-legged for breathing, for slow breathing. Okay, now when you're sitting, okay, your slow breathing के लिए सबसे पहले मतलब आप ट्राई करिए कि कितना हो सकता. So follow my count, you try and listen to the count. So in your later when you're practicing, you can see if you can do this count. Okay. So breathe in, 2, 3, breathe out, 2, 3, breathe in, 2, 3, breathe out, 2, 3. Do this a couple of times. Then you can try. Breathe in, 2, 3, 4. Breathe out, 2, 3, 4. Breathe in, 2, 3, 4. Breathe out, 2, 3, 4. Then you will increase it to breathe in, 2, 3, 4, 5. Breathe out, 2, 3, 4, 5. Even try if you can go breathe in, 2, 3, 4, 5, 6. Breathe out, 2, 3, 4, 5, 6. Yeah. This is only to understand how well you can breathe. Now, इसमें एक गलती बहुत लोग करते हैं, वो है जब आपको बहुत ही लंबी सांस लेने की, आपको 2, 3, 4, 5 तक जाना है. So people start doing this. Now this is not right. You're not supposed to be doing this. Okay. I will show you what is wrong and what can be right. Okay. So I'm showing you what is wrong. Okay. पहली गलती, you're moving your shoulders up and down consciously. आप खुद से कर रहे हो क्योंकि आपको लग रहा है कि ज्यादा सांस ले सकते हैं. दूसरी चीज, नाक से बहुत आवाज. You know, when you are breathing, ना आवाज is not important. Are you actually taking in so much air? Okay, कुछ breathing exercises में हाँ आपको आवाज निकालनी होती है. Okay, लेकिन when you're just doing slow breathing, you have to learn to breathe silently. ऐसे लगना ही नहीं चाहिए कि आप बहुत डीप ब्रीदिंग कर रहे हैं, क्योंकि आवाज में क्या होता है, आपको बहुत बार यहाँ पे स्ट्रेन आ जाता है. तो अगर आप ज्यादा देर तक वैसे करेंगे तो आपको शायद मतलब सिर में दर्द हो या फिर ऐसे गले में यहाँ पे दर्द हो, नाक में पीछे दर्द हो. तो यू शुड ट्राई नॉट टू डू इट फॉर वेरी लॉन्ग. अगर आप आवाज लेकर सांस ले रहे हैं कोई भी ब्रीदिंग एक्सरसाइज के लिए तो ज्यादा देर ना करें. Okay. Now I will show you what is correct. I'll tell you the count. I'll show you the count. Okay. यहाँ पे you can see my body become blow out because there is air going in. लेकिन ये नहीं है कि shoulders उठाए. Okay, that is not what you should do. One way you can learn this is आप अपने हाथ छाती के बाजू में रखिए. Okay, keep them near your chest, straight facing down. Now breathe in, breathe out. Breathe in, breathe out. So you see from the side, breathing in and out and you will be able to feel it. तो आपको पता चल रहा है आप कितनी सांस ले रहे हैं. Okay, this is only to understand. Okay, जब आप बाद में practice करें slow breathing, then you should know कि आपको वही चीज करना. Without holding your hand. Okay, that is only to understand. तो आपको एक ब्रीदिंग एक्सरसाइज सिखाऊंगी जो बहुत ही आसान है और आपको आपके डीप ब्रीदिंग की ट्रेनिंग के लिए बहुत अच्छी है. ओके, इट इज कॉल्ड 4-7-8 ब्रीदिंग. ओके, आपको ब्रीद इन करना है 4 काउंट तक, होल्ड करना है 7 काउंट तक, ब्रीद आउट करना है 8 काउंट तक. This you can count slightly fast. Start में तो breathe in 2, 3, 4. Hold 2, 3, 4, 5, 6, 7. Out 2, 3, 4, 5, 6, 7, 8. So you can just simply sit down. ज्ञान मुद्रा, कोई भी मुद्रा, आप बैठिए, आंखें बंद करिए, बैक स्ट्रेट, नेक स्ट्रेट, हेड स्ट्रेट. ऐसे नहीं बैठना. You have to sit straight. Roll your shoulders, sit back. Now, breathe in 2, 3, 4. Hold 2, 3, 4, 5, 6, 7. Out 2, 3, 4, 5, 6, 7, 8. शायद स्टार्टिंग में इतनी लंबी काउंट ना हो आपसे. यू कैन काउंट इट फास्टर, बट यू अंडरस्टैंडिंग ब्रीद इन थोड़ा कम काउंट में होता. यू शुड बी एबल टू होल्ड फॉर लॉन्गर एंड ब्रीद आउट इज ऑलवेज लॉन्गर. अगर आप ब्रीद इन 4 काउंट का कर रहे हैं तो ब्रीद आउट 8 काउंट का करना चाहिए. आइडियली दैट इज हाउ वी आर सपोज टू बी डीप ब्रीदिंग और ब्रीदिंग इन जनरल ऑल्सो. लेकिन हम नहीं करते. वी आर ऑल फास्ट ब्रीदर्स. नॉर्मली सांस लिए तो बहुत ही फास्ट और शैलो होती है. दैट इज वाई वी शुड प्रैक्टिस ब्रीदिंग, प्रैक्टिस प्राणायाम स्पेसिफिकली, वेरी कॉन्शियसली, दिन में एक बार तो. Yeah. Now another breathing technique which is very good for mental health is humming bee sound. Okay, अभी हम एकदम humming bee sound होता है जैसे आपको म तारा कहना है, म. और ये कहने के लिए what you'll do is open your fingers out, thumb you slightly place it near your ear opening. ये नहीं कि पूरा ही बंद करना है या फिर पूरा ही खुला छोड़ना है. Just near it. Yeah. Close your eyes. Sit straight, back straight, head straight, shoulders rolled back, always. Okay, you're going to sit. Close your eyes. Take a deep breath in. Makara. Keep your hands down on your knees. Keep your eyes closed and feel the vibration. ये बहुत ही आसान है and actually there are different versions कि आप हाथ कैसे रखते हैं. This is the simplest and it works very well. हाँ, तो आप try this and do the sound maybe 3 times. या फिर आप अगर आप जब शुरू करें शायद एक बार, शायद 2 बार. That's all, and just sit. You'll be able to feel the vibration in your hands. Yeah, that observation is very important. कि आपको कर रहे हैं, ठीक है, वो करना है, but after that to sit and to observe the vibration. कि आपको पता चले कि हो रहा है कुछ, हाथ में कुछ झंझना रहा है, आजू बाजू आपको कुछ लग रहा है कि आवाज अभी तक है. That is very important. Okay, this was the second pranayama we looked at. Okay. Another breathing technique which works very well for mental health is Sudarshan Kriya. Sudarshan Kriya is from Art of Living and it has got ample amount of research and analysis with results to tell you that what all it is good at and how it affects your mental health. So that is something I can't teach. You will have to take up a course from Art of Living, but I will definitely suggest it. Yeah, at least look at the research. Yeah, at least look and understand what kind of breathing exercises it is. Yeah. Now we looked at asana plus pranayam. We looked at pranayam. इसके बाद आएगा meditation. But before you do meditation, like you're just sitting and quiet and you're meditating, honestly, it is difficult. Okay. वक्त लगता है, it is not difficult, it needs patience and practice. Okay, तो इससे पहले what you could do is chanting. जैसे ओमकारा कह दिया 3 times. Normally we do, no, for yoga we'll say om 3 times, like the humming bee sound that we just did. Even that is very helpful. That, let's say you did 3 omkaras, do some breathing exercise. जैसे अभी हमने 4-7-8 करा, slow breathing करा, you can do that. Do the humming bee sound and then just sit. Or after that you can find something that you want to chant. जैसे Om Namah Shivaya if you want to chant. Or there are some people who don't like chanting, which is absolutely fine. You can just work with the vibrations. Omkara कह दिया 3 times, done. You can just sit down and feel the vibration. Okay, how to meditate correctly and to know whether you are meditating or not meditating will be a whole different chapter. It'll be a different session sometime. Okay, but all of these exercises that we did today are for mental health, and I really hope you will practice. At least pick up 1 or 2, see which ones you like, or if you were already doing it. ऐसे है कि ये तो बहुत ही आसान है, सभी कर ही रहे हैं, but to consciously do it, you will feel good कि हाँ इससे करा तो हाँ मेरा concentration अच्छा हुआ, balance कर रही हूँ, focus अच्छा हो रहा है. Even that will help. Yeah. So recap: asana plus breathing, pranayama and chanting, and then meditation. Okay, there were many options. I really hope you will practice. And I have finished 2 minutes before my time. Yeah, if we can start with some questions.
Sure. We'll start off with some question, Ms. Puri. Well, first question to you is this Jnana Mudra and Chin Mudra the same?
Okay, so this is like a problem because of different yoga practices. Okay, होता है कि नॉर्थ इंडिया में चिन मुद्रा कहते हैं, साउथ में ज्ञान मुद्रा कहते हैं, कुछ लोग ये ऊपर रखते हैं, कुछ नीचे रखते हैं. Now I haven't done a PhD in yoga, I've only studied yoga. So someday when I do a PhD, I will come to you with the correct answer.
Thank you, and I hope to see you soon with a PhD.
Thank you.
And the next question is, you said that you need concentration and focus while doing all this yoga. Now, this particular session, later on, of course, in this session, we deal with bipolar disorders and autism. Now, how do you deal with these patients? Because focus and concentration is extremely difficult so far as this bipolar patients are concerned.
Right, that is very important. तो इसलिए मैंने बताया कि अगर आपको directly, अगर आप जैसे 10 मिनट बैठ के आप ब्रीथिंग नहीं कर पा रहे, you can't do. It is very difficult even for a normal person. इसलिए आप शुरू करिए आसना से. आप शुरू when you I mentioned focus and concentration in one of the balancing asana. ओके तब अगर आप कोई बच्चे हैं जिन्हें ये प्रॉब्लम है और उन्हें बताइए कि आप एक पॉइंट पे फोकस करो, इट्स वेरी डिफिकल्ट फॉर देम. बट एज अ गेम इफ यू स्टार्ट इंट्रोड्यूसिंग कि आप एक पैर पे खड़े कितनी देर हो सकते हैं, कैन यू जंप ऑन वन लेग एंड देन मूव टू द अदर साइड ऑफ द रूम, आप छोटी छोटी चीजों से शुरू करिए. ओके, डेफिनेटली विल बी डिफिकल्ट. आई एम नॉट सेइंग इट इज इजी. दैट इज व्हाई ऑल द आसनास आई गेव, they're always the easiest solution. Then you can find a difficult version.
And have you dealt with patients with bipolar disorders?
I have honestly not. No.
But you have a separate section on yoga for these people. Is it different or is it?
So normally when I take yoga therapy, I specialize in kids, in yoga for kids. Okay. So let's say I have a student like that. I will start with playing games. That has to be the solution. You have to be like, अगर आप उन्हें breathing exercise सिखा रहे हैं, okay, you can't say breathe in 2, 3, 4, 5. नहीं करेंगे. Give them a balloon, ask them to blow, ask them to leave it, ask them to blow it bigger, and then ask them to leave it. Now these are some creative techniques we have to come up with, and they have to be different for every student.
Sure, you can ask a question.
Yes sir, thank you. मिस माती, मेरा एक सवाल है. इनफैक्ट एक में ही 2 सवाल है। पहला ये कि क्या कोई आसन ऐसा है जो मेंटल हेल्थ को प्रिवेंट कर सके, डिसऑर्डर को, मेंटल हेल्थ डिसऑर्डर को। दूसरा इसके साथ ये है कि क्या जो मेंटल हेल्थ प्रॉब्लम के शिकार हैं, बाइपोलर डिसऑर्डर के शिकार हैं, उनसे कराया जा सकता है आसन? चैलेंजेस क्या हैं?
ओके, तो सबसे पहला ना, जो कौन सा आसन कर सकते हैं। Now all of these I said were solutions and have to be combined together, कि आपको क्या चीज से तकलीफ है, then you combine and you mix and match. It has to be different for every student. हाँ, तो आप ये नहीं कह सकते कि इस डिसऑर्डर के लिए ये 5 आसना है। एक्चुअली अगर आप गूगल करें तो आपको 5 नहीं 10 भी मिलेंगे, क्योंकि आपको बहुत सारे आर्टिकल्स भी मिलेंगे, बट डिपेंडिंग ऑन what you like, what you can do, what phase of life you are in, then you should choose. दूसरा, आपने पूछा कि क्या चैलेंजेस है और इसके लिए है या नहीं। सबसे बड़ा चैलेंज ये है कि योगा में बहुत ज्ञान है। ओके, इट इज वन ऑफ द ओल्डेस्ट स्टडीज, और योगा में आयुर्वेदा भी है, आप में मेडिटेशन है, चैंटिंग है, क्या कुछ नहीं है। बट that study is not as accurately done as medicine. जैसे मेडिसिन में आप कह रहे हैं कि आपको कोल्ड है तो ये 5 दवाएं हैं, 5 में से एक आप ले सकते, कोई डॉक्टर आपको प्रिस्क्राइब करेगा, आप प्लीज ये लीजिए। या फिर आपको कोई और डिसीज है, आपको एक मेडिसिन है जो आप दे सकते हो। योगा इज नॉट स्टडीड दैट वे, और इवन इंडियन कल्चर इज नॉट स्टडीड दैट वे। तो समवेयर देयर इज अ गैप कि डॉक्टर ये बता रहे लेकिन डॉक्टर नहीं बता पा रहे कि आप ये आसना करिए, योगा थेरेपिस्ट बता रही है कि आप 2-3 चीजें ट्राई करिए। तो somewhere I'm sorry, I can't give a correct solution to this.
थैंक यू माती जी, थैंक यू। आपने हमसे बात की और आगे भी हम आपसे बात करते रहेंगे। वैसे योगा के बारे में ये कहा जाता है कि योगा का अगर आप नियमित रूप से आसन करें तो मानसिक शांति तो मिलती ही है, शारीरिक फायदे के साथ साथ, और कम से कम जो चिंता और फिक्र लोग करते रहते हैं हमेशा, उससे मुक्ति मिलती है। थैंक यू वेरी मच, आपने ज्वाइन किया। आगे भी हम आपसे बात करते रहेंगे।
थैंक
यू वेरी मच।
और अब वक्त है हमारे खास सेगमेंट योर हेल्थ काउंटर का। आज का टॉपिक है मेंटल हेल्थ इन पर्सपेक्टिव ऑफ कोविड-19 एंड देयर आफ्टर, जिस पर बात करेंगे देश के जाने माने मेंटल हेल्थ विशेषज्ञ डॉक्टर निमेश देसाई। निमेश देसाई का नाम मेंटल हेल्थ केयर के पर्यायवाची के रूप में लिया जाता है। कहीं भी मेंटल हेल्थ केयर का जिक्र हो और डॉक्टर निमेश देसाई का नाम ना आए, ऐसा हो ही नहीं सकता। डॉक्टर देसाई का इंस्टीट्यूट ऑफ ह्यूमन बिहेवियर एंड अलाइड साइंसेस दिल्ली से संबंध है, वहाँ वो डायरेक्टर है संस्थान का, और संस्थान के विकास में बड़ा योगदान है इनका। इस संस्थान को नेशनल इम्पोर्टेंस का संस्थान बनाने का क्रेडिट डॉक्टर देसाई को भी जाता है, जहाँ उन्होंने 11 साल से अपनी सेवाएं दी, हेड ऑफ साइकियाट्रिक डिपार्टमेंट के रूप में और मेडिकल सुपरिटेंडेंट के रूप में भी। हम डॉक्टर निमेश देसाई का अपने शो में स्वागत करते हैं। डॉक्टर साहब, डॉक्टर निमेश देसाई से विस्तार से बातचीत करेंगे मिस्टर आर शंकर। मिस्टर शंकर हील फाउंडेशन के प्रेसिडेंट हैं। वह हील फाउंडेशन ऑर्गेनाइजिंग कमेटी के हेल्थ राइटर्स और एडिटर कन्वेंशन के चेयरमैन भी हैं। मिस्टर शंकर का जर्नलिज्म में 30 साल से भी ज्यादा समय का अनुभव है। अब तक वो 200 से ज्यादा हेल्थ राइटर्स वर्कशॉप और 7 नेशनल हेल्थ राइटर्स एंड एडिटर्स कन्वेंशन का आयोजन कर चुके हैं। ओवर टू यू मिस्टर शंकर।
Thank you, Kishore. It's wonderful to have you with us, Dr. Desai. I think every session that we have with you is a new experience for us, and I'm sure this session is also going to be a new experience for us. In fact, we keep on discussing about what you said in the earlier episodes also. So I will start off with a straight question to you, that what were the mental issues seen during the COVID in probably various segments, like vulnerable population, including healthcare providers, COVID survivors, disabled and older adults, children and adolescents. I will start with vulnerable population, including healthcare providers.
Thank you, Shankarji. It's always such a pleasure to be with Hill Foundation, you, Shankarji, Kishore Malviya and our friend Dr. Swaleep, of course, who tends to remain behind the curtain after doing everything. One factual correction. I finished my tenure with IBAS, the organization, as of 31st December 2021, after 23 years. And so I'm now a free bird, so to say. So such a pleasure to be here. And मुझे एक विचार आ रहा है before we go further. Our young yoga teacher, I think the minutes that I heard was giving wonderful advice. Can I just clarify from the 40 years of clinical psychiatry practice कि आप दोनों जो पूछ रहे थे शंकर जी और किशोर जी, two brief things I want to say about yoga and persons with mental disorders, especially bipolar. क्या कोई ऐसा आसन है जो सारे डिसऑर्डर्स को प्रिवेंट कर सके? आई एग्री विद अ यंग फ्रेंड, परहैप्स नॉट. ऑल दैट कैन हैपन इज पॉजिटिव मेंटल हेल्थ के लिए जो आसन मुनासिब समझे वो किए जाए. फिजिकल एंड मेंटल हेल्थ बीइंग सीन एज वन यूनिट. Specific asan for specific disorders I think will be a little difficult. But more importantly, those with diagnosed mental health problems, bipolar disorder or OCD or schizophrenia or severe depression or a few others, I have learned over last 30 or 40 years gradually more and more that there are some clinical situations when yoga or meditation may not be appropriate. So a person with active schizophrenia symptoms or severe OCD symptoms or depression or in mania, many conditions, may not be appropriate. तो मैं clarify ये करना चाह रहा हूँ कि 20-25 साल पहले भी होता था, अब और चल पड़ा है कि योग एक panacea है for everything, anything and everything, and that's fine by and large. Yoga being a good curative, promotive and preventive practice for all health issues, but not in some psychological conditions, especially with psychiatric symptoms. So मैं जैसे कह रहा हूँ, मैं as a psychiatrist सीखा हूँ कि फैमिली से और उस कंसर्न व्यक्ति से बात की जाए कि हो सकता है आपकी मौजूदा मानसिक स्थिति में अभी योग की कोशिश न करें, 2-4 हफ्ते के बाद दवाई का असर जब हो जाए तब फिर योग प्रैक्टिस शुरू करें. तो ये ध्यान रखना बड़ा अच्छा होगा. To come to your question, Shankarji, primarily I would divide it this way. It's now 2 years that we have finished the epidemic, 2 years duration. In the first year, 2020, it was more of anxiety, fear, dread of the unknown, of the infection, of what might happen, and a few experiences of people going through, including healthcare professionals and other frontline workers. I really include गहरा संबंध रखते हैं. मुझे एक चीज अक्सर सूझती है कि फ्रंटलाइन वर्कर्स में डॉक्टर्स, नर्सेज, हेल्थ केयर प्रोफेशनल्स को इंक्लूड कर लिया जाता है, and so do the police and the law enforcement people. But we often forget at many levels that media professionals, especially photojournalists and field reporters, have actually had a lot of trauma of the epidemic. And they kept the information going for all of us through their work. But all of these frontline workers, in 2020, it was more about the fear, not knowing what will happen, and also the reasonably satisfying experience of growing with science. जैसे आप दोनों समझते हैं, जानते हैं, बाकी साथी समझेंगे. I somehow by nature and by conviction refuse to look at only the negative of any experience for myself or for humanity. And so while in 2020 there was a lot of fear, anxiety and also a lot of people, law enforcement people, doctors and nurses and media professionals in their own field were learning how to develop science, how to implement good scientific practices, and how to disseminate scientific information to the general population so that the epidemic gets controlled. So that was a very exciting experience in that sense. 2021 was bad. I must say I corrected myself because I used to believe based on past experiences in the world and in this country that our populations will generally deal with it well और ज़्यादा depression और ऐसा असर होगा नहीं. लेकिन second wave ने जो तबाही मचाई, the mayhem that the second wave caused definitely led to a lot of trauma, depression cases being on the rise, suicide attempts and completed suicide being on the rise, and a whole lot of other mental health problems. So the second year, 2021, was more of the severe trauma on various fronts, depression and stuff. And now we are in April 2022 at a stage where I'm very excited again to talk about where can humanity go from here in terms of mental health, especially Indian society. And I'm sure in the next 30 or 40 minutes, we'll talk about that under different heads. But this is a very exciting point of time for us to learn the mental health ropes, and I emphasize the word in block capitals, appropriately. Neither underdo nor overdo the emphasis on mental health. And we'll come back to that.
So hopefully now that the road ahead is somewhat clearer, and the COVID hopefully is behind us. Some people say there is another wave coming.
Yeah, yes.
What do you expect? How do you see mental rehabilitation taking place, especially for after the 2 years?
Yeah, Shankarji, that's a damn good question. Can I bring in what again is since my medical school days, and I hope both of you and all of our other colleagues agree. Definitely from the viewpoint of mental health, if not, I think also as a trained public health professional for entire issue of health, if not beyond health to human existence, I don't think there is a good alternative to the slightly outdated, some people say, biopsychosocial model. Definitely in mental health. And so I'm going to kind of now and in the next 30 or 40 minutes, going to keep talking about things in the tripartite model of biopsychosocial model and components. But add to that the economic, if not also political. Mental health so depends on biology, psychology and behavioral sciences, social work and social sciences, and economics and politics. Now in that, biologically speaking, the first thing, Shankarji, for us to get across to our friends and colleagues is that for those people who went through COVID infection, and most people did, but those who went through COVID infection in a moderate to severe mode, symptomatic, maybe through ventilatory and ICU experiences, there is a real issue of long COVID or post-COVID as it's called. And the long COVID or the post-COVID syndrome again has effects and symptoms caused from effects on the brain, the mind, and the rest of the body organs and systems. So I myself experienced this. I went through COVID infection in the second wave. Touchwood got out since there was no comorbidity, and I was lucky. For a few months, if you actually have physical or psychological symptoms of lassitude, lack of energy, not feeling interest in anything, and a whole lot of stuff, that's actually post-COVID syndrome. So let's recognize the brain and the mind and the body-based post-COVID syndrome and give it due respect. Two, those who went through, coming to the psychological aspects, those who went through the ICU experience or the ventilatory experience, obviously the trauma continues. There were people who got into depression and their depression got better, but that possibility still remains. The third part, significant number from our own circles who lost their closed ones, and who lost their closed ones in a very difficult situation. As we have often said, the last ride not being completed, the closure not being possible, possibly dissatisfaction with the care that the near and dear one got. And so, this is the time to examine to oneself or to share with colleagues or to encourage friends and colleagues to talk about those experiences. The best thing can be sharing and ventilation. So that the last part in that line, I do believe, and there's some data to suggest, and from my own hospital experience, that a large part of depression cases that we saw were not really, so to say, de novo new cases of depression. Let's be clear. There were people who were genetically susceptible to bipolar disorder or recurrent depressive disorder, where the trauma or the negative experience of the epidemic in one or the other form brought up that as a clinical syndrome. Now that has been brought up, triggered by the final straw, so to say, of the epidemic effects, the disorder continues to manifest. And so those people who had recurrent depressive disorder or OCD or bipolar disorder manifesting for the first time in last 2 years need to recognize that that is not going to go away just because the epidemic is over. If I, as Mr. X, had genetic susceptibility and I had one of those disorders manifesting, I now need to recognize myself as a person living with mental health problem. And so give it all the attention that that mental health problem deserves. We will, I'm sure, Shankarji, talk about the social and economic aspects in a while, because that's a separate game altogether.
Fine. While dealing with all this, the segment of the population, how do you see rehabilitation of children?
Great question. I might have said this on Heal platform also earlier.
Yeah, but it's worth repeating.
I know, no, the specific aspect, sure. One attribute amongst a few others of humans that we humans understand about us as humans is the resilience, the ability to bounce back. I really believe is almost limitless for individuals, for human race, and definitely to make a small but strong point for South Asian communities and people in South Asia and India. So that resilience is great. Mostly nature and resilience will take care of the rehabilitation. For children and adolescents, much as we adults don't realize, that resilience is even better. The adaptation to new circumstances. During the 2 years, they had to do something else. Now they have to get adapted to a hybrid normal. So by and large, have faith and trust in the resilience of the majority, while recognizing that there will be a small group of people, children, adolescents, or adults or elderly, who may not have the same resilience, who will require attention and care. So the tricky part is that while we don't want to psychiatricize or psychologize unnecessarily everybody's natural recovery, and we should leave them to themselves, majority, that small number of people who require help, how do we help them identifying themselves? How do we help their family and friends identifying themselves without judgmentality, without making them feel negative, and give them the support that they deserve? So indications of resilience not working, as again what I said about long COVID. If there is continued negativity in thought or mood changes over a few weeks or months, definitely if there is any suicidal thought, that's a red flag. If there is significant sleep or appetite disturbance, if there is significant impairment in family relationships or occupational functioning. So identify those people, and I keep repeating this, majority will do well on their own. They don't need a psychiatrist, fortunately. But that small number of people who require professional help, psychologists, social workers, and psychiatrists, the trick is in identifying them early. So that's the twin job that the society needs to do. And I've already introduced the idea that I will build towards the end of how our society needs to avoid over-psychiatricizing. Yeah.
And I remember in your earlier episode, you had mentioned about the great resilience of the migrant population, where I think you had it was very well dealt with. But one thing I want to ask you is, you spoke about this long COVID. There is a general tendency among people that if there is any ailment, they will generally blame it on the long COVID. Now, how do you distinguish between the real fear and the made-up fear?
Excuse me. The thing to realize, Shankarji, is that, like I said about 2020, and that's still true about long COVID. Medical science and us clinicians, everybody, mental health, in physical health field, we are all learning as we go along. And so doctors are also still recognizing. The overlapping parts are this. First of all, make sure there is a good physical screen, including laboratory investigations. Again, from my own experience and from near and dear ones and the patients that we see. Vitamin B12 deficiency, vitamin D deficiency, calcium deficiency, or other such deficit states. These are fairly common in general population. They have become more. So we need to get the clinical assessment and the laboratory test done so that this can be easily corrected. Second, not to forget simple things like hypertension, thyroid, and the other non-communicable diseases that bring in those symptoms of lassitude. See, I'm going to say something very pithy, Shankarji, you and I can both have a laugh at it. Let the general population not make the mistake of believing that with COVID, all other disorders and health problems have disappeared. Right? They all remain. And so, like we did before 2020, for anybody with those symptoms, screening for hypertension, diabetes, thyroid, the common problems, then yes, if at all there is the persistent symptoms and the psychological screen, the deficiencies screen has been done, the routine NCD screen has been done, a mental health screen has been done, then you come to accept that yes, this might well be post-COVID. The important part is to differentiate these 3 or 4 parts. And this is where I feel so excited in some ways. One more opportunity, not only for us doctors and health professionals to integrate mental health and health practice, but also for the general society to realize. If I might say here, one positive spin-off amongst many of the epidemic is that mental health is on the agenda of the society. We are talking about it more, which is nice. I have a caution there not to overdo it, which I'll come to towards the end. But the opportunity that I think we have in the healthcare field and in the society is to recognize that overlap between physical and mental health. See, like I keep saying ad nauseum, all generations have written those school essays, including the famous one, A Sound Mind in a Sound Body. But we all forget to apply it when it comes to our own health status. That physical and mental health will have to be seen as conjoint, existing together by each one of us, by the doctors, by the family.
We have now a segment of population who would say that COVID is over, now it's better to get on with life. I'm sure you're going to deal with this in the economic part of it when you come later. And there is the other segment which who constantly live in the fear of either a new wave or a long COVID. Now, how do you balance these two? Because sometimes when you go down, I was just discussing this before the session started. I was saying that let us not have too many COVID sessions because we need to go ahead. But then, Sudeep was telling me that no, that is fear still going on because people still discuss about COVID, and so there is this fear. But at the same time, people who are more interested in economic activities, they said, no, let us put this all behind and move forward. So what's your view on all this?
For individuals and families to try and locate yourself on that graph. It's a bell-shaped curve like almost everything else, log normal. So for myself or for my family and friends to recognize where do I place myself? Am I the careless one on one end of the spectrum? Then I better become a little more careful. Or am I the excessively fearful one, anxiety-prone person? Okay. Or do I happen to be lucky in the middle of the spectrum where I'll take due care? Identify yourself, identify your weaknesses, your strengths, and act accordingly. That's at the micro level. Meso level, organizations, teams, neighborhoods, like I said earlier, that twin sensitivity of letting people be, I agree with Swati, letting people be, let normal life get on, while being sensitive to those few who require help. At the macro level, Hill Foundation's programs, policies, at the state or national level, again, there will be that correct mix. Resilience with caution.
Wonderfully put. I think that's excellent, the way you balance the whole spectrum of population. Now, I will ask you to come back to the socio-economic thing that you said you refer you.
Yes. I must say that like I corrected my own thinking in 2021 in the second wave and after that, that's also true about the socio-economic aspects, especially economic aspects. And let's deal with the economic aspects first, since we have opened that, before we come to the social aspects. I realized only in the latter part of 2021, and I continue to see that in hospital clients, in the private practice clients that I see now, and in my friends and neighborhood and social circles. Many of us who might be lucky to have occupations which remained stable, including us frontline workers. See, one of the merits of frontline workers has been that there's never been an occupational disruption. You know, some media persons are losing their jobs, of course, by now. There is that, but so we may not easily realize how many sectors have actually a huge rollback. Hospitality, the most predominant one, you know, the broad spectrum of, and a whole lot of others. And that with this recent global war threat, with the hike in the fuel prices, is not helping at all. So there is a real problem of economic slowdown that individuals and families are going through. I'm saying this as much to myself and to my colleagues in mental health as I'm saying to the larger group. It's very easy if I'm comfortably placed to overlook the economic hardships. But there is real economic hardship. There again, my thought is this. While it is real, while we need to be careful about helping those children, adolescents, mothers in the families who are going through economic hardship and, you know, facing it, how do you help them psychologically? Or can there be sound economic policies? That's another debate altogether. But I also think, Shankarji, that, and this is more as a social scientist and as a citizen, but drawing from whatever mental health learning I get. In the blind race for hedonism, material acquisition, and everything else that with full respect, late 20th century capitalist democracy-based models of the West was imposing on the world, which also affected climate. Here is a chance for human race to realize the value of how life can be good with minimal needs. What Gandhiji referred to as aparigraha, acquire only as much as you need, you know, is actually, this is the time for human race to learn. I'm talking about something that's fairly difficult to convey to a mother who is managing a household with limited money, granted with full empathy. But for all of us, individually, families, societies, we need to realize that, and I'll repeat myself, that almost uncontrolled rush for material acquisitiveness and money and comforts and luxuries, I think is good to review and slow down. You know, does a family of 2 or 3 members require 5 cars? Does every room in a large household have to have an air conditioner? You know, from smallest examples. But decidedly, it's difficult. And to go back to my other favorite theme, economic hardships also, or even social circumstances, family issues, affect those who are vulnerable. So those who are genetically susceptible to depressive disorder or bipolar, or those who are psychologically vulnerable to developing mood disorders, they get affected by the economic and the social circumstances. So our constant endeavor needs to be, can we, in a positive framework, identify those who are vulnerable and help them towards professional services? You know, can I also say about the social circumstances, Shankarji, very briefly? Domestic violence, intimate partner violence, of course, a lot of people have now begun paying attention to, and what effect that has on the women, on the children. Elder abuse or at least passive neglect is also a reality. And so perhaps there needs to be a little more emphasis, again at micro meso level, on elders in the community, in the family. But the crucial part is that the psychological issues of whatever each one of us went through, one's own life circumstances, somebody was getting engaged, somebody was getting married, somebody had a child, somebody lost a parent or a sibling to COVID or non-COVID causes. Life hasn't come to a stop in these 2 years, like I said about other diseases. So how do I help somebody deal with those normal life circumstances and the interpersonal relationship issues that a lot of people have faced. Can we, again, in the positive framework, it seems to me that, like we said about less materialism and more, meaningful existence paradigm, can we now learn as human race to be a little more detached with issues of day-to-day life? Attachment, emotional attachments with adequate detachment. That virakti ki bhavna, that ability to live life with dispassion or lack of excessive passion is one more lesson that I really think we need to learn. I hope you realize, I know you're smiling, we need to talk about not only those with mental health problems, but we also need to talk about what can we, the majority, so-called normals, those who haven't had mental health problems, what mental health lessons can we draw from this epidemic, for human race?
I was actually laughing, not laughing, I was smiling because I appreciated your philosophical bent of mind in all this, because you have done. So I was wondering whether you have become a philosopher also after this particular episode. So apart from Gandhi, I think even Sri Lal Bahadur Shastri also had mentioned that satisfaction is trying to learn with what you have.
Shankarji, I will really keep myself brief, but allow me. You see, again, I mean, I'm no great admirer nor hater of the Western world. Western world has had its contributions to the global development and human history. But I think really that this whole thing about happiness index is also a bit overrated and Western. Happiness is not essentially the core concept in our way of life or psychology. Eastern thought was more about satisfaction, as you said. Sukhi hona, santusht hona जीवन में, rather than खुश होना. See, so I all that my request to all of us is, whenever you read here, talk about happiness index and all of that stuff, just juxtapose the idea of happiness with the other concept of being satisfied with life, being content. Contented with life is as important as being happy. In fact, I individually would say, for myself or for human race, if I might take the liberty, contentment is a tad more important than happiness.
Very true. And in this context, I just wanted to say, Narayan Murthy's wife, Sudha Murthy, had mentioned that satisfaction comes when you learn to let go. So if you let go, then of course that is the way that you satisfy yourself.
For those of our younger colleagues who might be more into the current TV series, I know, Shankarji, if you follow Sheldon Cooper.
Yes.
We all should learn to be a little less like Sheldon Cooper. He's an excellent characterization to learn what not to do.
Okay. Now, I'll just move on to another issue is, during the COVID and during, especially the second wave, we had a lot of these cases of suicides, especially in children and in vulnerable population. Now, do you think that we need to redouble our effort to address the people who are in the brink so that, they don't slip?
You put it beautifully. People, like I've been saying a couple of times in this conversation, for people who are psychologically susceptible, vulnerable, and those who are genetically predisposed to depression and mood disorders, by family history, by past history, by personality profile, or by social circumstances, if you can identify without being judgmental, and they themselves should realize, or family and friends can help, that regular monitoring would be good, that he or she is not getting into depression. People on the brink, as you said. But the positive part again of this, while there is definitely huge effort that needs to be doubled or trebled or quadrupled for suicide prevention and identifying depression early, as you said, I also want to assuage people's apprehensions that, and I've by now seen quite a few clients who went through COVID and went into depression. For most of them, my sense is, and I think the epidemiological evidence is coming up, these are not new cases of depression. The COVID epidemic did not lead to new cases. There were only two major groups. Shankarji, allow me, and I hope we have a little time. Yes, we do.
Yes, we have time.
See, what contributed to the apparent new cases are two major groups. Let me quickly say this. The Indian figures for mental health problems is about 10%. You know that. So in India, 10 out of 100 or 1 out of 10 people will have a diagnosable mental health problem. For the global figure, that is 25%. So we are lucky. We have mental health problems less frequently than the world. Definitely less than the US away. But the important part is this. Out of those 10 people who are with mental health problems in 100, only 2 people were reaching any mental health service. Shankarji. There was treatment gap of 80%. So out of any 100, if 10 were diagnosable and deserving treatment, 8 were not getting anywhere. Now what we are seeing is a few of those 8 people coming forward. So the hidden treatment gap cases are coming forward. We should not make the mistake of believing that depression is rising. It was already there, it was hidden, it's now coming forward, which is great. The second is, like we said, those who were taking treatment earlier, who might have neglected, who thought they were over it, now it's a recurrence or relapse. So most cases of depression and suicide are those who were already susceptible or were already there. Not too many new cases. I still believe human resilience is very good. But to repeat, yes, doubling up our efforts at every level to see that people with depression or people with mood disorders or people with mental health problems get identified, get supported, and get proper help. And to repeat myself, Shankarji, what I said at the start, one good way of doing it is sharing. Again, I'm not too sure if I've said this on Heal Foundation platform, but when I say sharing, and when I say sharing is caring, I always have it in mind as a bilateral reciprocal process. I should feel comfortable to talk with you or Swadeep or, Kishorji about my issues. But more importantly, am I creating a milieu where you and Kishorji and Swadeep or any other team member feels comfortable to talk with me, human to human? Forget my psychiatrist role. Okay. So be open to sharing your feelings, but more importantly, be receptive and be nice enough so that others can share their feelings with you. That multilaterality in a society will help. Not to consider, and there's a caution here. See, most often what people in the society end up doing is, if a friend or a family member says, I'm feeling low, I'm feeling depressed, or I'm not feeling happy, I need help. Oh, there is nothing. Yeah, don't worry. It's all in the mind. Get over it. Doesn't help. Don't trivialize somebody's psychological experience, now especially in this post-COVID era. Amongst many other things, I hope we have all learned, and I hope we all keep learning, to be sensitive to somebody's psychological narrative. At least don't trivialize, don't judge, don't criticize, because what that person needs, first of all, is an understanding ear, empathy.
Right. As the Buddha said, the art of hearing is far, far superior than the art of speaking. I think
absolutely, sir. Absolutely, sir.
So I'm glad that people who actually didn't take help for mental issues are now slowly coming forward. But again, stigma is a big issue. How actually can this be addressed? They don't come for
one way of one way of doing it, Shabdaji, will be, like we said, neutralize the psychological narrative. I mean, if you or I, now that we have known each other a little bit, and we get to know each other better, or Sudeep or I, or you and I, if one has an issue and one talks about it, genuinely, why should my respect for you or vice versa go down? What Rogerian principles emphasize unconditional positive regard. I sincerely believe, and I've said this on many radio and television programs and now digital platforms, to those who call up, phone-in programs, Shankarji.
Yeah.
I always say to them, but let's generalize it here. It requires courage to talk about one's weakness or one's feeling of low. So let's recognize, let's genuinely respect I genuinely respect people in my friend circle or social circles who come forward and talk about it, or like I said, who talk about it on radio or television phone-in programs. Being emotional, being vulnerable, being sensitive, or even suffering from a mental health issue is not a sign of weakness. It's a sign of strength to come forward and say, I have a problem. Like that tennis player said, it's okay not to be okay. Yeah. I hope that happens in our culture. Let me come to towards the end. Let me come to that part of international perspective. See, the Western society, especially the American society, kind of did very well in destigmatizing, your question. But I also think that they have kind of gone far too ahead. And I believe that they have psychiatry establishments, pharma industry, drug companies, and the basic insecurities of life, the way they have dealt with it, many factors put together. And I think, genuinely, with all respect, Americans tend to overdo anything that they do. मतलब जो भी करेंगे वो 300% करेंगे, वो प्रॉब्लम है. उसमें क्या हो गया है? That they have what I think is over-psychiatricized the society. Allow me to explain. Every small day-to-day experience of thought or feeling or behavior that anyone goes through or notices in the other person need not be seen as a psychiatric disorder. Irritation, anger, feeling low, feeling anxious, arguing, fighting, whole lot of human attributes. So let's recognize that it is okay to be within that normal range. What I really do believe, and there is enough controversy and debate happening in the US also among psychiatry and mental health groups, that let us not turn every small day-to-day experience into a psychiatric label and start giving medications. Let's recognize, again, it's a very thin line between day-to-day experiences of emotion, thought, behavior vis-a-vis psychiatric disorder. But it's important to learn. Like I said, allow me to come back to that. See, in India, the prevalence for psychiatric disorders is 10%. Global figures are 25%. The American figures are 49%.
New Zealand figures are 100%. Okay.
So the trouble is, and I see a lot of my good friends, William Balkrishna is here. I saw Dr. Golecha, many good friends from psychiatry and others. It's so good. I really would love to get debate, maybe some other platform or maybe the second part today. We have a difficult job, Shankarji. All of us in Afro-Asian context. On the one hand, we want to increase mental health awareness. We want more people who can benefit from treatment to reach there, including what you reducing stigma. On the other hand, we don't want to repeat the overcorrection that the Americans seem to have done. We want to keep that psychiatric mental health awareness within reasonable limit. How do we do that? Allow me to also say this. What is very important in our context is this, and our own research that we did in the last decade, Delhi, Lucknow, Chennai, and a lot of other research actually points out that by now it's not the stigma alone that's an issue. We looked at the causes for that treatment gap, Shankarji, 80% that I mentioned. And stigma was ranked number 3. What were the top 2 ranking causes for not reaching mental health service? 1, lack of awareness that it's a mental health problem in the society. 2, even if the family recognized that it was a health problem or a mental health problem, they did not know where to reach and how to reach. So, while working on reducing the stigma, yes, absolutely, Vaniti. Awareness about it being a health problem, that needs to be increased, and increasing how do I access, how do I reach there.
So I will request, of course, for you to stay back for the next session because you have already said.
Wonderful to, there's some great friends here,
Next, of course, you have all your friends also over here, so I think it's just a big home. Now, before I move on to the next session, I'll just ask you, I'll just set the ball rolling. Now, Every year, the World Bipolar Day is observed on March 30, which just went by. It's observed in coincidence with the birthday of celebrated Dutch painter Vincent van Gogh. Can you throw more light on this particular aspect? Because you have dealt with other people who are...
Yes. We have our own examples of mood disorders and creativity. Meena Kumari, Gurudat, who we lost at 39 to suicide. So internationally, there are a lot of examples of that connect between Leo Tolstoy, the most, right? So there is that issue of celebrity, examples of recurrent depressive disorder or depression with alcoholism and bipolar disorder, with or without suicide, with highly creative minds. See, the trouble, Shankarji, if I might lighten the atmosphere a little, is this. Eccentricity is often associated with brilliance. Okay, but not always so. Most brilliant people are eccentric, but not all eccentric people are brilliant.
Right.
So while mental health problems are associated with creativity, let's not make the mistake of believing that anybody who is creative is necessarily with a mental health problem. That's a dangerous idea. But yes, it becomes difficult. What is nice, and allow me to emphasize, I'm sure my colleagues will continue this, for about 30 or 40 years now, if not 50 years, bipolar disorder or recurrent depressive disorder, or indeed entire set of mood disorders, I think, is one group of health problems where prevention is possible.
Right.
Prophylaxis.
Right.
There are very few health problems where effective lifetime prophylaxis is possible. I think we need to get this message across through you and Hill Foundation and such platform to the society that psychiatry is no less than any other health specialty in delivering services. In fact, in a few considerations, it's a step ahead.
Yeah.
There are not too many health problems where lifetime prophylaxis is possible. So the positive part for those with bipolar disorder diagnosis or depression, RDD, or any other mood problems is this: not to despair at all. With correct psychiatric treatment and counseling and your self-monitoring, your life with mood disorder can be as normal as anybody else's, if not a shade better.
Of course, I'll just add on to what you said. There's a saying that the line between a genius and an eccentric person is very, very thin. So I think that's where it is. But before I move on, I'll just ask a brief question before we move on to the second session. Have the criminal justice system across the world and India viewed people with bipolar disorders in kinder light since the violent acts are not under their control?
What we should do, perhaps, Chankarji, I'll answer that briefly, but maybe we should really someday plan the whole issue of legal aspects and mental health problems in civil and criminal issues. See, marriage and annulment and divorce is a major issue, property issues, whole lot, criminal cases. Yes, the law and the society are beginning to see people with mental health problems in a kind of light, but that's a very debatable issue because, allow me to say this, insanity as defense, if I might say, is a very seductive topic. Milan and Vaniji and my other colleagues know it's a very favorite Viva question and a short essay note in our question papers, MD. But even in the US, for all their strengths and weaknesses, the success rate, the ultimate success rate for insanity as defense is 1%. So it gets thrown up more often than it gets succeeded.
Yeah. Thank you very much, Dr. Nimesh Desai. I think, as usual, it is always wonderful having you with us because you move from field to field, from psychiatry to medical to social, economic, philosophy. And I think for each of the session, we need you as a separate, discuss it separately. Thank you very much. But please stay on for the next session because you have a lot of
great pleasure. I'll be happy to be a listener.
No, you will have to speak also. Yeah.
And Milan and Vaniji, Dr. Gulecha Saab is here.
Yes.
I know why he's not putting his video on. Gulecha Saab.
Hello.
Namaskar, sir.
Good morning to you.
Namaskar, sir.
Nice listening to you. And I welcome you. And you are really say highlighted many issues which are novice.
सर आप तो
That
हमारे
is what we
सीनियर है, गुरु
expect
हैं
out of you.
सर.
So anyway,
Thank you very much. We will now move on to the second session, and I request the admin to play the session intro video. Welcome back. We now move on to session 3. But before that, I'd just like to remind our viewers that we are live on Facebook and YouTube. We have a very important session on bipolar mental health and bipolar disorders. And every year, World Bipolar Day is observed on March 30, which just went by. To speak on this and other issues we have with us, unfortunately, the first two speakers couldn't join us, Dr. Ginny Gopinath and Dr. Sonia Lal. We have with us Dr. Milind Balakrishnan, a consultant psychiatrist, Messina Hospital, Mumbai. He has over 11 years of experience as a consultant psychiatrist with a specialization in anger management, cognitive behavior therapy, psychotherapy, adult marriage, marital counseling. He's working with NGOs, including Bipolar India, to fight stigma and raise awareness. He has been the secretary of Bombay Psychiatric Society, a 60-year-old organization of mental health professionals in Mumbai. We also have with us very senior Dr. G.R. Gulecha, who is currently associated as a senior consultant psychiatry at Kailash Hospital, Noida. The next is Dr. Vani Kulhali, consultant psychiatrist from Nanavati Hospital, Mumbai. She has over 18 years experience in the field of adolescent and child psychiatry. She is a member of various organizations, including the Indian Psychiatric Society and Indian Medical Association. Last but not the least, we have Ms. Shreya Verma, a licensed clinical psychologist providing psychological services and including individual psychotherapy for adults and physiological assessment of emotional and mental health difficulties with children and adolescents and adults. Before I start off with the session, since Dr. Golecha has to leave a bit early, I hand over this session to my friend Kishore Malviya, who will deal with Dr. Gopinath and with Dr. Golecha and Dr. Nimesh Desai. Over to you, Kishore.
थैंक यू मिस्टर शंकर। मेरा पहला सवाल डॉक्टर GR गोलेचा से है। डॉक्टर साहब, आपका वीडियो नहीं दिख रहा है।
I'm here. I don't know why I am not coming on the screen.
आपका वीडियो लगता है कि स्टॉप किया हुआ है। डॉक्टर साहब, हमारे यहाँ ओल्ड एज में ज्यादातर लोग डिमेंशिया, हाँ अब ठीक है डॉक्टर साहब।
Now this has come.
जी। हमारे यहाँ ओल्ड एज में ज्यादातर लोग डिमेंशिया या अल्जाइमर के शिकार होते हैं, ज्यादातर लोग।
Your voice is very kindly loud, little louder. I am not able to hear properly.
Now, okay, sir?
No, it's there, but can further raise the volume.
Okay, sir. Now you can hear me?
Yeah.
डॉक्टर साहब, हमारे यहाँ ओल्ड एज में ज्यादातर लोग डिमेंशिया और अल्जाइमर के शिकार होते हैं, ज्यादातर लोग। क्या ये बीमारियां प्रिवेंटेबल हैं?
देखिए, अल्जाइमर्स, यस, certain efforts have been made. Totally preventable तो नहीं है. We cannot, say nullify them. They will be there because even the certainty about the life is not there. One has to go from this world. So as we grow, our systems gradually undermines our resources, and physical health as well as mental health goes. Alzheimer's, there are many theories and you all know about it. We can only defer the progression and improve the quality by certain newer medication which has come. And I think that is what in practice also we are regularly dealing with, and that's why we are finding that more and more patients are coming when they find that, because the biggest burden of Alzheimer, as you mentioned, is on the caretaker. Patient is obvious of it. It doesn't bother about it, but the caretakers, and they will, when they find that, yes, there is some medication, somebody can help and improve upon the things, then the patient's flow increases. And accordingly, as I see in my OPD, yes, there are many geriatric patients comes and they have got some or other cognitive deficit along with certain element of depression and many other things. So you have to, give a comprehensive checkup, including the physical investigations and all that. And according to your clinical sense, as you decipher that how much is the cognitive involvement and how much is the depressive involvement and all. And accordingly, the psychopharmacology comes to our rescue, and definitely we benefit. We titrate the doses of the medications from the small one. We tell them, we give them a briefing that they should not discontinue and they should not lose the patients. Ultimately, definitely they will be better off. But it will not the question that you take a medicine and everything is all right. It will take few weeks and months. And that pays them because, the caretakers, they want some relief, something to be provided. Otherwise, the daughter-in-law in the house, the other, because taking care of elderly is very, very difficult, especially they have got the Alzheimer's and leading to dementia and all those things. So the clinical problems are there. So this is what it is. And newer medications definitely helps them, especially cholinesterase inhibitors and all those things. So that is what it is. I think today's talk was on bipolar.
Yes, sir. उस पे भी है सर। हमारा ये शो इस समय दुनिया भर में YouTube और Facebook पर लाइव देखा जा रहा है और कुछ क्वेश्चंस भी हमारे पास आ रहे हैं जिसको हम लेते हैं। हमारे पास जोधपुर से एक हमारे दर्शक हैं, जोधपुर राजस्थान से। वो पूछ रहे हैं कि क्या मेंटल हेल्थ रिलेटेड जो प्रॉब्लम्स होते हैं, खासकर डिप्रेशन, इनका परमानेंट क्योर संभव है क्या?
देखिए, there cannot be a one line answer for this thing. Permanent solution का सवाल ही नहीं आता. Even life is not permanent. It is the interplay of the, your personality, your genetic formulations, as well as the stress factors, your ambitions, your achievements, all those things. So at all the stages, and even in the history, if you see, this is there. So cases are there where there is a genetic loading, and if that is so, that is a different thing. There cannot be a permanent solution. But all the conflicts and all the stresses, if they are properly resolved, yes, practically it may lead to a relief, and a better relief for a long time. And that can be called as a permanent relief. The antidepressant therapy which has come, there are various models. Because, sir, it is now half a century I am in psychiatry. And when I joined psychiatry, we could not imagine many things. Even the treatment of Alzheimer's were not there, and even depression, etc. And only ECT was the one treatment and few drugs. Now we have got, so many drugs to suit every kind of patients, which provide the relief. And if you are experienced enough, yes, you can definitely give them. And assurance is there, the permanent relief is not there. Say, for example, blood pressure. All the, routine things, thyroid, etc. We have to continuously give the medication. So same way, after the acute, the active stage subsides, then the maintenance therapy starts. And maintenance therapy means only, less than 50% of the original medications. And that they continue, then it is practically amounts to permanent relief. And even if they don't, the doctor may not say so, patient find his own way. ये गोली लेता हूं और मेरे को आराम रहता है. And he continues. After a few years, when he develops some complications or somebody says, then they come, अरे मैं तो इनकी treatment ले रहा था और इनके लेते हैं, and then they come for consultation, what should I do now? So what I mean to say is permanent relief as such, just the word suggests cannot be there, but a long-lasting relief can be thought of and does occur in patients with depression also, if appropriate doses of medication is continued as a maintenance therapy.
डॉक्टर साहब, एक बात हमेशा कही जाती है, क्या बाइपोलर डिजीज पर्सनालिटी को पूरी तरह से चेंज कर देता है? बाइपोलर डिसऑर्डर,
देखिएगा, पर्सनालिटी को चेंज करना, व्हेन द डिसऑर्डर इज एक्टिव, देन द पर्सनालिटी टेक्स द शेप and the behavior becomes accordingly, whether he is in a manic phase, he is in a hypomanic phase, or he is in a depressive thing. And it is never a lasting thing. As soon as the person is put on treatment, or the time frame changes, then the behavioral changes will be there, and this is the permanent change in personality. I can't say that by, say per se, but we can modify the abnormalities of the behavior to a great extent, and he becomes more
मैं
amicable.
कुछ बोलना चाहती हूँ, डॉक्टर वाणी हियर. तो ये पर्सनालिटी का ऐसे होता है कि बिकॉज बाइपोलर डिसऑर्डर ये बहुत लंबे समय तक चलती है, और अगर कुछ उसके सिम्टम्स रह जाते हैं ट्रीटमेंट में, तो दैट कैन समटाइम्स बिकम अ पार्ट ऑफ द पर्सनालिटी. और अर्ली ऑनसेट बाइपोलर डिसऑर्डर जो हम देखते हैं कि जो बच्चों में ऑनसेट होता है, डेफिनेटली दैट चेंजेस द ट्रैजेक्टरी ऑफ द पर्सनालिटी. और कभी कभी बाइपोलर डिसऑर्डर के कुछ सोशल कॉम्प्लिकेशंस इतने भयानक होते हैं कि पेशेंट अंदर से हिल जाता है. तो इसको हम बोलते हैं पर्सनालिटी चेंज ड्यू टू सीवियर साइकियाट्रिक इलनेस और लाइफ चेंजिंग इवेंट्स. सो इससे पेशेंट अगर बाइपोलर डिसऑर्डर से रिकवर हो भी जाता है, तो भी उसकी पर्सनालिटी में एक तरह का डर या एक तरह का लो कॉन्फिडेंस हम देखते हैं. और इसीलिए द ट्रीटमेंट ऑफ बाइपोलर डिसऑर्डर इज नॉट मियरली गिविंग द मेडिसिन, बट उसके बाद उसको काफी सारा हमको काम करना पड़ता है कि वी हैव टू ब्रिंग अप हिज कॉन्फिडेंस, वी हैव टू ब्रिंग अप द मोटिवेशन, so that the personality and the family interactions are restored. And यही हमारा rehabilitation counseling है. So definitely personality is affected with bipolar disorder, and because it's a chronic and a very severe illness.
थैंक यू मैम, हम अभी आपके पास आएंगे, आपके लिए हमारे पास बहुत सारे सवाल हैं. डॉक्टर गोलेचा, एक सवाल और, ये GAD-7 टेस्ट क्या है, जनरलाइज्ड एंजाइटी डिसऑर्डर टेस्ट, और ये कितना इफेक्टिव है?
Beg your pardon, just repeat please.
ये GAD-7 टेस्ट क्या है, जनरलाइज्ड एंजाइटी डिसऑर्डर टेस्ट, और ये कितना इफेक्टिव है?
I could not get you. The voice is a little low.
First, हमारे, यस सर, आ रही है आवाज?
हाँ अब आ रही है।
सर ये GAD टेस्ट क्या है? जनरलाइज, आप सुन रहे हैं, जनरलाइज एंजाइटी डिसऑर्डर टेस्ट, और ये कितना इफेक्टिव है?
I could not get you. I could not get you. Very.
सर मैं आपके पास दोबारा लौटूंगा। मैं चलता हूँ फिर डॉक्टर देसाई के पास।
सर मेरी किशोर जी, मेरी रिक्वेस्ट ये है कि हमारे दो साथी हैं मिलन और वाणी जी, मैं तो काफी बोल चुका, आई एम हैप्पी, बट व्हाई डोंट वी टेक दिस टू कॉलीग्स, है ना? आपका आदेश है, लेकिन हाँ मिलन और वाणी बताएं, बहुत बढ़िया बताएं।
ओके सर। डॉक्टर वाणी, मेरा पहला सवाल आपसे है, अभी आपने बच्चों का जिक्र किया।
हाँ जी सर।
चिल्ड्रन में बाइपोलर डिसऑर्डर की क्या स्थिति है हमारे देश में? क्या कोई स्टडी हुई है?
ये चिल्ड्रन में बाइपोलर डिसऑर्डर की बहुत ज्यादा स्टडीज नहीं है, बट दो की स्टडीज है, एक 98 में हुई है और 2004 में हुई है। और दोनों स्टडीज में ये पाया गया है कि बच्चों में जो बाइपोलर डिसऑर्डर होता है उसकी रिस्पांस बहुत अच्छी होती है मेडिसिन देने पे, कि जिस सिम्टम्स या जिस प्रॉब्लम्स के साथ वो आते हैं डॉक्टर के पास, वो बहुत अच्छी तरह से रिस्पॉन्ड कर जाते हैं। बट ये होता है कि उस मेडिसिन को चलाते हुए भी उनको कुछ ना कुछ रिलैप्सेस आने की संभावना होती है। तो इससे हमको ये केयरफुल रहना पड़ता है कि आगे इसको रिलैप्स न हो, इसीलिए इसका फॉलो अप और इसको ज्यादा ध्यान देना पड़ता है, क्योंकि अगर ये रिलैप्स होता जाएगा तो जैसे मैंने पहले बोला कि इनकी पर्सनालिटी और साइकोलॉजिकल और फिजिकल डेवलपमेंट में भी नेगेटिव इफेक्ट हो सकता है। तो ये दो की स्टडीज है यहाँ पे इंडिया में की गई।
मैम एक बात बताइए, क्या ये सच है कि बाइपोलर डिसऑर्डर महिलाओं में ज्यादा कॉमन है? अगर है तो क्यों?
नहीं सर, एक्चुअली बाइपोलर डिसऑर्डर जो होता है वो जेंट्स और लेडीज में इक्वल प्रोपोर्शन में होता है। बट डिप्रेशन जो होता है जिसमें एक हाई फेज हम नहीं पाते हैं और उसको हम बोलते हैं रिकरेंट डिप्रेसिव डिसऑर्डर। उसमें सिर्फ जैसे बाइपोलर और डिप्रेशन का अंतर ये होता है कि बाइपोलर में मूड ऊपर भी होता है और नीचे भी होता है, बट डिप्रेशन में मूड केवल नीचे ही होता है। तो उस स्थिति में बाइपोलर डिसऑर्डर जो है वो लेडीज और जेंट्स में समान प्रोपोर्शन में पाया जाता है, बट डिप्रेशन जो है, रिकरेंट डिप्रेशन जो है, वो महिलाओं में ज्यादातर पाया जाता है। इसके काफी रीजंस बताए जाते हैं कि एक तो महिलाओं में हार्मोनल साइकिल्स होते हैं, ऑनसेट होता है उसका, मेनोपॉज भी होता है, तो उस समय में उनके ब्रेन पे जो इफेक्ट्स होते हैं इस पे होता है। दूसरा, समाज में जो महिलाओं का एक स्तर है कि काफी सारे उनको स्ट्रेसेस झेलने पड़ते हैं, इससे भी उनका डिप्रेशन काफी बढ़ता है। कुछ सोसाइटीज में महिलाओं को अच्छी तरह से न्यूट्रिशन भी नहीं दिया जाता है, इससे उनकी डेवलपमेंट या उनकी जो बाकी जो विकास है उनका मानसिक या शारीरिक विकास वो भी कम स्तर पे होता है। तो ये सब रीजंस, कुछ स्टडीज में ये भी पाया गया है कि महिलाओं का जो सोचने का स्टाइल है कि कोई भी एक सोच होती है तो मन में चिपक जाती है, उसको वो लोग कवर अप नहीं कर पाते हैं, उसकी वजह से भी शायद महिलाओं में डिप्रेशन ज्यादा है ऐसा बोलते हैं। बट मेन रीजंस तो ये है कि हार्मोन्स है और सोशल स्ट्रेसेस है।
थैंक यू डॉक्टर वाणी, आप हमारे साथ बने रहिए, हम सेकंड
हाँ,
राउंड में फिर आपके पास आएंगे। डॉक्टर देसाई, अमेरिका में एक स्टडी हुई थी कि बाइपोलर डिसऑर्डर ब्रेन को पूरी तरह डैमेज कर सकता है। ये मेरे ख्याल से 2006-07 के आसपास हुआ था। भारत के संदर्भ में ये क्या है, कितनी सच्चाई है?
किशोर जी, ऐसा है कि ये जो प्रीडोमिनेटली बायोलॉजिकल रिसर्च है उसमें इतना जरूरी नहीं है कि अमेरिका, यूरोप, एशिया, अफ्रीका में अलग अलग रिसर्च हो। सी दी हार्डकोर क्लिनिकल प्रैक्टिस जो है और उसके जो ब्रेन या बॉडी मैकेनिज्म्स हैं वो सिमिलर रहेंगे, तो वहां हम डेफिनेटली यूएस या अमेरिकन या यूरोपियन स्टडीज से ले सकते हैं। जहां सोशियो कल्चरल इश्यूज है वहां जरूरी है कि हम इंडियन रिसर्च अलग करें और ढूंढें। ये जो जैसे डॉक्टर वाणी ने बहुत अच्छे से बताया था पहले, कोई भी बीमारी जो ब्रेन और माइंड से संबंधित है, एपिलेप्सी, मिर्गी का दौरा हो, स्किज़ोफ्रेनिया हो, बाइपोलर डिसऑर्डर हो, अगर वो यंग एज से मिडिल एज, लेट एज तक बार बार एपिसोड होंगे तो उसका कुछ ना कुछ असर होना ब्रेन पे और खासकर साइकोलॉजी सोशल एस्पेक्ट के कारण संभव है। जैसे डॉक्टर वाणी बता रही थी, काउंसलिंग और प्रिपरेशन ऑफ द पर्सन एंड द फैमिली सो दैट दोज इफेक्ट्स कैन बी लेस इज वन वेरी गुड थिंग। मैं फिर कहूंगा जो मैंने पहले कहा, बाइपोलर डिसऑर्डर में प्रिवेंशन ऑफ फ्यूचर एपिसोड्स और स्किज़ोफ्रेनिया जैसी बीमारी में प्रिवेंशन ऑफ रिलैप्सेस एंड रिकरेंसेस वो बहुत क्रूशियल है लंबे अरसे की बीमारी के जो नेगेटिव इफेक्ट्स होते हैं ब्रेन पे, है ना। सो आई गो अलोंग विद डॉक्टर वानीज अर्लियर स्टेटमेंट टू से दैट करेक्ट मेडिकल ट्रीटमेंट with medicines, counseling and preparation of the person can actually bring it down significantly.
डॉक्टर देसाई, मैंने ये सवाल डॉक्टर गुलेचा से पूछा था लेकिन मेरी आवाज उन तक नहीं पहुंची है। अब वो मिस्टर शंकर की आवाज शायद पहुंचे, वो बाद में पूछेंगे। मैं आपसे पूछना चाहता हूं कि जनरलाइज एंजाइटी डिसऑर्डर टेस्ट जो होता है गैड, वो कितना इफेक्टिव है?
ऐसा है किशोर जी कि बिकॉज साइकोलॉजी, साइकियाट्री, मेंटल हेल्थ में हम क्या कर रहे हैं, वी आर ट्राइंग टू अंडरस्टैंड। मान लीजिए मैं आपका क्लाइंट हूँ, आप मेरे साइकियाट्रिस्ट हैं, है ना। तो आप बतौर साइकियाट्रिस्ट मेरे मन में, मेरे दिलो दिमाग में जो अंदरूनी अनुभव चल रहे हैं उसको बाहरी रूप से ऑब्जर्व करके समझने की कोशिश कर रहे हैं। सो साइकियाट्री, मेंटल एक्सपर्टीज इज अबाउट ऑब्जर्वेशन एंड इन्फ्लुएंस ऑफ द इंटरनल सब्जेक्टिव एक्सपीरियंस, which is not always easy. स्टैंडर्डाइजेशन जरूरी है कि भाई वाणी और मिलन और हम और गुलेजा साहब एक समस्या को एक रूप में देख सके। You know, we should not have too much variation. तो इसलिए ये क्वेश्चनर जो है वो और इवॉल्व हो गए। एक तो सब्जेक्टिव फीलिंग्स एक्सप्रेस हो सके, सेकंड स्टैंडर्डाइज वे में असेसमेंट हो सके, सबकी अपनी गति से न चले अलग अलग डॉक्टर, और तीसरे रेप्लिकेबिलिटी ओवर टाइम कितना हो सके उसी इंस्ट्रूमेंट से। उसके भाग रूप ही जो कोई भी इंस्ट्रूमेंट है, डिप्रेशन के रेटिंग स्केल्स हैं, एंजाइटी के रेटिंग स्केल्स हैं, यू नो, डिमेंशिया के रेटिंग स्केल्स हैं। एक चीज और मैं आपके माध्यम से बाकी साथियों को तो बताना चाहूंगा, जो ब्रॉड कैटेगरीज है, एक तो स्क्रीनिंग इंस्ट्रूमेंट है। भाई 50 जनों को हमने जीएडी या डिप्रेशन रेटिंग स्केल दे दिया कि इसमें से कितने लोगों को संभव है कि फलाना डिसऑर्डर है। पता चला कि 50 में से ये 15 है जिसमें एंजाइटी थोड़ी ज्यादा है, डिप्रेशन है। फिर उसको सेकंड स्टेज पे एसेस किया जाए कि सीवियरिटी कितनी है। तो स्क्रीनिंग इंस्ट्रूमेंट्स बहुत यूजफुल है आम जनता में, स्ट्रेस के लिए, एंजाइटी, डिप्रेशन के लिए, अल्कोहल के लिए, टोबैको के लिए। मुझे खुद मालूम करना है कि क्या मैं उस ग्रे जोन में हूं, क्या मुझे डॉक्टर के पास जाना चाहिए, क्या मुझे कुछ करना चाहिए। और आजकल डिजिटल वर्ल्ड में बहुत सारे ये स्क्रीनिंग इंस्ट्रूमेंट्स रिलायबल वेबसाइट्स पे अवेलेबल है। इनफैक्ट मैं ये लिबर्टी लूंगा, छूट लूंगा सुझाव करने की, किशोर जी आप और शंकर जी और स्वदीप और बाकी टीम ये सोचें, हम लोग सारे जो हैं यहाँ पैनल पे विल बी हैप्पी टू हेल्प यू। हील फाउंडेशन की वेबसाइट पे मेंटल हेल्थ प्रॉब्लम्स के लिए एक सेक्शन हो सेल्फ स्क्रीनिंग इंस्ट्रूमेंट्स, यू नो, एंजाइटी, डिप्रेशन, अल्कोहल, स्ट्रेस, है ना।
बिल्कुल बिल्कुल,
तो ये बड़ा अच्छा होगा। हाँ, बड़ा अच्छा होगा। मिलन, व्हाट डू यू से मिलन?
या एब्सोल्युटली, आई थिंक ये जरूरी है क्योंकि वैसे भी मतलब अगर आप ऑनलाइन जाएंगे तो बहुत सारे स्केल्स मिलते ही है, पर एटलीस्ट स्टैंडर्डाइज स्केल्स मिले और उस हिसाब से लोगों को एटलीस्ट सही जगह से स्क्रीन कर पाए। नहीं तो बहुत सारे स्केल्स है और अक्सर पेशेंट्स हमारे पास आने के पहले बहुत कंफ्यूज हो जाते हैं, बहुत सारे स्केल्स खुद पे अप्लाई करके वो खुद ही नहीं समझ पा रहे उनके साथ क्या हो रहा है।
बहुत अच्छा सुझाव है डॉक्टर देसाई, हम इस पर जरूर विचार करेंगे और इसका लाभ उठाएंगे। हम आगे हैंडओवर करेंगे शंकर जी को, शायद शंकर जी की आवाज डॉक्टर गुलेचा तक पहुंच सके, लेकिन उससे पहले हम चाहते हैं कि एक छोटा सा वीडियो दिखाएं मेंटल हेल्थ पर।
देखिए थोड़ी मोड़ी परेशानी अगर हम देखें तो आजकल सबको है, बिकॉज डिजायर्स आर गोइंग रियली हाई, एवरीबॉडी इज रीचिंग, ट्राइंग टू रीच देयर बेस्ट। जब भी आप जरूरत से ज्यादा एफर्ट्स अपनी बॉडी और ब्रेन के साथ करते हैं तो इट इज डेफिनेटली कॉज होंगे ही होंगे। इसका कहने का मतलब ये नहीं है कि आप ऊंची उड़ानें भरना बंद कर दें, लेकिन सही तरीके से ऊंची उड़ानें भरने से आप मानसिक तनाव से या मानसिक परेशानियों से दूर रह सकते हैं। कुछ तरीके हैं, जैसे कि आप सोशली एक्टिव रहें, अपने लोगों से मिलें। अपने लोगों से मिलने का मतलब ये नहीं है कि आप अपनी चीजों में अपनी एक्टिविटीज को छोड़कर आप दोस्तों में ही लगे रहें, लेकिन कभी कभी एक मौके पर आपके कुछ तो ऐसे मित्र होते होंगे जिनसे आपको मिलना, बात करना पसंद होता होगा, तो फ्रीक्वेंट सोशलाइजेशन करें। हमारे कई व्यूअर्स और कई लोग हैं जो कि अब्रॉड रहते हैं, अपनी सोशल और पर्सनल लाइफ को छोड़कर अपनी फैमिली से अलग दूर वो लोग अब्रॉड में हैं। इस टाइम पर अगर आपको लग रहा है कि आप कॉन्स्टेंटली अंडर स्ट्रेस है या कोई चीजें पर्टिकुलरली आपको तंग कर रही है, तो बहुत इजी सॉल्यूशन है। एक है डायरी राइट। Journal writing helps you to bring out your things which is undergoing in your head, which you can't discuss with anyone. There are points which you won't like to discuss with anyone. They are too personal to share. ऐसी चीजों के लिए आप हमेशा जनरल राइटिंग कर सकते हैं। जरूरी नहीं है वो जनरल राइटिंग आपको किसी को पढ़ानी ही है, आप अपने पास रख सकते हैं, चाहे तो उसको बाद में यूज कर सकते हैं या उसको फाड़ कर फेंक सकते हैं। एक दूसरा तरीका है सेल्फ सीबीटी, सेल्फ कॉग्निटिव बिहेवियरल थेरेपी। इसका प्रोसेस है कि आप एक्चुअली जिस भी चीज के बारे में आप बहुत लंबे समय से परेशान है या बहुत लंबे समय से सोच रहे हैं, वो भी 5, 6, 10 विचार जो भी हैं उनको एक कागज पर लिख लें। एक कागज पर लिखिए और आप देखेंगे कि उन सवालों में एक थीम नजर आ रही होगी, आपको एक पर्टिकुलर चीज, एक पर्टिकुलर परेशानी नजर आ रही होगी। वही एक परेशानी है जो आपको कॉन्स्टेंटली तंग कर रही है और आपको मेंटल हेल्थ डिसऑर्डर्स की तरफ ले जा रही है। अगर आप ये सिम्टम्स बहुत शुरू में ही पिकअप कर लेते हैं कि मैं बहुत सोच रहा हूँ, मैं बहुत उदास हूँ या मुझे ये पर्टिकुलर चीज तंग कर रही है, तो आप डिसऑर्डर्स की तरफ जाने से रुक जाते हैं और परेशानी को पहले रूप में देख लेते हैं। इसका मतलब ये नहीं है हर परेशानी सॉल्व की जा सकती है। कुछ परेशानियां ऑर्गेनिक होती हैं, कुछ मेंटल हेल्थ डिसऑर्डर ऑर्गेनिक होते हैं, जिसका आपकी डायरी राइटिंग या सेल्फ सीबीटी से भी बहुत फर्क नहीं पड़ेगा। जहां आपको इनिशियल सिम्टम्स से एक मेंटल हेल्थ एक्सपर्ट को मिल लेना चाहिए, वो काउंसलर, साइकोलॉजिस्ट, साइकियाट्रिस्ट कोई भी हो सकते हैं। तो कुछ इस तरह की चीजें करते थे। इनिशियल लेवल पे ही अपने सिम्टम्स को पहचान लेना, इनिशियल लेवल पे ही लोगों से बात कर लेना और उस चीज से बाहर निकलने की कोशिश करना आपको बड़े मेंटल हेल्थ डिसऑर्डर्स की तरफ जाने से बचा सकती है।
Over to you, Mr. Shankar.
Thank you, Kishore. Welcome back. Before I move on to the questions, it's just a small reminder that we are live on Facebook and YouTube. Now, I'll move on to Dr. Milind Balakrishnan. Dr. Milind, this year's World Bipolar Day theme is Bipolar Together. The International Bipolar Foundation states that a recent survey found that 77% of Bipolar 1 participants said living with disorder made them feel isolated or alone, and 81% said they felt like no one understands what they're going through. Your comments?
Sure. Yeah, I think with most chronic mental health disorders, patients eventually face these issues. One, because of the sort of social impact, for example, loss of jobs with episodes, gradually also loss of friends, loss of connections. So this is definitely an impact in whether it's bipolar disorder, schizophrenia, any chronic mental illness. This risk is always there, and this isolation leads to a lot of secondary depressive symptoms as well, and also increases risk of suicide. I think I'd like to add here about the great work that Bipolar India is doing. Disclaimer being, I'm on the trust board of this organization, but the kind of work they're doing is unique because there is no real pure support group for bipolar disorders in India, and they run this out of Andheri. So it was started by a patient and is continued by him, and now it's developed into a full-blown organization, which is also registered as an NGO now. And So they have a support group that meets every 2 weeks. And of course, in the pandemic, they were doing it online, but now they've started meeting physically again. And the kind of impact that meeting people who have suffered and are doing very well gives to those who are struggling with the early phases of bipolar disorder is amazing. They absolutely start believing again that they are capable of working again and leading absolutely successful lives. So I think that's something that is very important here.
Yeah, you said a very valid point. You know, the idea of bipolar victims sharing their vulnerability is still relatively new in India. What more should be done?
Right. So I think that's where again, like Dr. Desai said, we have a lot of building awareness is happening, but one, we should be wary of whether we're doing too much, and at the same time building awareness along with the resources need to be commensurate with the awareness that we build. Otherwise that's also a problem, because if we build resources and build awareness and resources are not available, specialists are not available, then we are going for trouble again. But yes, so raising awareness about, because bipolar disorder is a very specific neurobiological entity. So raising awareness that it is a medical illness, it is a medical problem, and can be treated effectively. And prevention of episodes is very, very important. It prevents, like we discussed earlier, this whole every time there is a new episode, I don't know, we shouldn't call it brain damage as such, because that sounds very scary, but it's more of a micro trauma to the brain. So there is this micro trauma that's building up, and over a period of time, cumulatively, it starts affecting memory, cognition, ability to process information, all of that over time. And that's where also the personality changes, the impacts that happen over a period of time seem to come from. So this is a cumulative damage that's taking place over a period of time. So I think raising this awareness and bringing people together to support each other is something that we all must do. All mental health professionals definitely are working hard to fight stigma, to raise awareness, but somehow we need to consolidate these efforts. We need to bring it together, and we need to have that's the other thing that Bipolar India does. When a psychiatrist raises awareness, he seems like an interested party. When a patient raises awareness, it very clearly shows that yes, there is a need for this awareness, and people listen much more than listening to a mental health professional, because they identify with that this is a person who has lived the experience. So the question of lived experiences comes up. Sharing of lived experiences is something that is vital.
Shankar sir, can I add something?
Please go ahead.
Sir, I think the issue of isolation also should be understood from a life span perspective. So if you see that a lot of bipolar disorder, among all the psychiatric disorders, if you see, bipolar disorder is the one which has the earliest onset. It's a early to late adolescent onset. And what we need to do here, I see a lot of children who have come in manic episodes or depressive episodes, and because of their increased energy levels, they are actually treated for hyperactivity. So the first agenda I would like to put here is to raise the suspicion of bipolar disorder among pediatricians and general practitioners. So if a child says that I'm not feeling well, you have to listen to the child. You can't really say that, no, this is not it. And sort of, so a lot of late adolescents whom I see, they do not feel understood because nobody listened to them, because nobody escalated. Even a psychiatrist who is not able to treat should defer to another psychiatrist who probably has a more experience or something, that my patient is not doing well despite of my efforts. See what more can you do. This is a lesson in humility for all of us in the medical professional and in the mental health professional. Next issue with isolation also is that the kind of symptoms that come in bipolar disorder, they're just within the range of normal but completely unsocial behaviors. There is risk taking, there is sexual escapades, there is recklessness, there is spending, and people can't understand why this person is behaving like this. It's difficult. So somebody with a disorder like schizophrenia, you can understand, you can easily make out the person is not thinking right, he's not behaving right. But it's very difficult when a person is in a bipolar episode. He seems to be doing everything right, speaking so lucidly and so nicely, cheerful, everything, and he seems to have no concern for his family or friends. The third social issue is the unpredictability. Somebody who is promised a certain thing, he to deliver, he needs a kind of stability. If that stability is not brought into his life, bipolar disorder hits out at this level, so there is no stability in the bipolar, and that is where this isolation. And what happens when we give a multimodal, I'm not talking merely about psychopharmacological treatment, but a treatment like Milan said, that biological treatment, individual counseling, vocational rehabilitation, and support group. When we do all these four, then we provide a kind of stability to the patient. And a lot of times, when we have provided all these things, after 2-3 years of treatment, families come back and have told us, madam, iski to personality aise thi, achhi thi, shant thi, pata hi nahi tha hame. We thought this fellow was a goner, he's a wastrel. So I think we need to understand that the disease hits out at the core of what it is to be a human in relation to another human being, and that is why there is so much isolation, and we need to do something about that.
Right, wonderfully put, Dr. Vani. I think whenever children throw tantrums or that they misbehave, or their general tendency is they're hyperactive, and the question of bipolar doesn't come in at all. I think a cross-referral is, of course, very, very important in this case. I hope Dr. Golecha can hear me.
Yeah.
Oh, wonderful, Dr. Golecha. Dr. Golecha, what is the difference between bipolar 1 and bipolar 2 disorders?
Well, they all fall in the category of mood disorder, and leaving apart the unilateral depression, which is a severe one, we come to the bipolar. Bipolar 1 means what you used to call mania. There is a manic episodes of different, either one time or repetitive manic episode, and may have certain depression also at other phase. As far as bipolar 2 is concerned, it is mainly the depression along with some hypomania, less than the mania, hyperactivities and all those things. That is mood elevation is low. So that is the bipolar 1 and bipolar 2. We can say that bipolar 1 means the mania, bipolar 2 is the depression, but depression along with hypomanic episodes.
Are there other types of examples also, like bipolar and related disorders induced by certain drugs or alcohol, or due to medical conditions such as Cushing disease or multiple sclerosis or stroke?
Well, they don't fall into the bipolar definition as a criteria. But yes, depression can be there, and depression is usually found in many other medical conditions and otherwise also. So we have to differentiate it. As far as the treatment modality lies, it depends upon the clinical appreciation of the case and the symptomology which the patient presents, whether he is in the high mood or he is in the low mood, and then what degree and how much, what is his age factor, right from even the kids are now developing this bipolar disorder, and old people are always there with this. So it all depends upon the clinician's own judgment as to which drug has to be given and to what extent, and this thing. The remission is achieved in few weeks.
Dr. Golecha, a new recent study which came out, a brain imaging study of young people at high genetic risk of developing bipolar disorder, has for the first time found evidence of weakening connections, between the key areas of the brain in later adolescence. How these networks developed prior to the condition was a mystery. But now, how do you view this for future interventional strategies?
Again, I am sorry.
I'll repeat it slowly. A new brain imaging study of young people at high genetic risk of developing bipolar disorder has for the first time found evidence of weakening connection between key areas of the brain in later adolescence. How these networks developed prior to the condition was a mystery earlier. How do you view this for future intervention strategies?
I think, yes, this is a good field to be explored further. And because imaging study and all, it is an ongoing process. More and more knowledge is being added and the new theory come out. Definitely, because what we may say mood disorder is only a mood disorder, but brain is the organ which all these things occur. Even emotional interplay, whether it is a low or high, it is all the functions of the brain and the limbic system. Certain areas are earmarked for certain functions. So this can be there of various degrees, and as we proceed in the research activities, and more objective approach will be there, and we will be able to decipher it. At present, well, there is nothing much to contribute to this. Only we study that and we accept that.
Thank you very much.
Since it's about adolescents, can I jump in again?
I will. Before you jump in, I'll ask Dr. Ms. Shreya Verma to jump in so that she has been listening for quite some time.
Yeah.
Ms. Shreya, I will take on from what Dr. Vani had said, that when you meet, you of course specialize in children. So when children come in with certain things, parents don't actually recognize that it is a bipolar disorder. And generally there is a thin line between hyperactivity, between misbehavior, between, throwing tantrums and bipolar. So how do you actually distinguish all this?
Symptomatically, it's very different. Symptoms of ADHD and mania, although they can feel similar, but bipolar disorder, like everyone's been talking about, is primarily a mood disorder. So your mood will be affected. So you'd have to speak to the parents in your clinical interview, speak to the do an observational interview with the child. Symptoms of ADHD would more be that they're not able to sit in one place. They would be either inattention or hyperactivity, which is kind of different from symptoms of mood, which is that mania would always go along with depressive symptoms as well. So you'd have to speak to the parents to understand if there are episodes where the child feels depressed, there are episodes where the mood feels elated. So the symptomatic presentation would be different. That's how you gauge it.
So yesterday also was World Autism Awareness Day. Now, it is said that autism spectrum disorder can be managed through early detection. What's your comment on this?
Early detection is always helpful. I think, early detection would help if you're able to detect it early, if you're able to, I think we were talking about education, psychoeducation, and speaking more about this. Dr. Nimesh Desai brought up a point of making tools available, screening tools at least available on websites. So education and working with communities would be very helpful, because then they would be able to understand what are the things that you have to notice in your child to be able to detect that something is not right. A lot of the times the parents don't even realize that there are some symptoms that are coming up. So early detection would be helpful.
Dr. Desai, your viewpoint?
Can I throw in a googly at Shreya and Vani and Milan, of course.
Please take your pads so that you defend the Google well.
Everything that's been said is actually very good, and there are a few points to make that I'll come to. But the googly, Shreya, and I'm sorry, I'm a bit stimulated on this Sunday morning. See, you're quite right that ADHD vis-a-vis presentation of mania for a clinician would be fairly easy. But as Dr. Vani was saying, for the parents and for family physicians, sometimes they miss out. But that's one part. It can be done by, as you said, by interviews and observation. My issue, googly, is how do clinicians or even family members deal with it when you have a young adolescent with autism spectrum disorder who might develop bipolar disorder, and that's fairly frequent, or ADHD with bipolar. So the googly, Vani, is that ADHD with bipolar or autism spectrum disorder with bipolar.
So we do that. So that's what the psychiatrist training is about. We try to treat the people with multiple disorders, and we have to treat both issues with on their merits. And when the patient presents, of course, the priority has to be given to the bipolar disorder, because nothing can be done when the mental illness is current. So we have to stabilize the mood of the patient, and then we have to work towards whatever the ADHD issue is there or the autism issue is there. And what I wanted to say with the previous research finding that Shankar sir shared was that it just tells us that bipolar disorder is something that that hits out at the core, that is the brain development. And so early intervention and good intervention will be a saving thing for these adolescents whose brain networks are at stake. And these are the adolescents who have a genetic risk, who also need to be told to stay away from psychotropics, because we know that psychotropics can also cause brain damage, and they can cause worsening of the bipolar disorder. So there is an education where it's like all other disorders. If you are having a risk of a certain disorder, you should be counseled earlier that what is something that you cannot do and what is something that is okay for you. So these adolescents need education, these adolescents need surveillance, and these adolescents need complete treatment so that future life trajectory is not impaired.
I think those are great points. Can I say that I'm sure Milan and Vani would agree. See, the imaging study that you spoke about, Shankarji, talks about the negative effects. What is I think noteworthy is that there is already good research in the imaging literature for so-called normal population as well as with people with disorders, that the corrections will also get reflected in the imaging findings. So what Milan and Vani were talking about earlier about reducing the isolation by, let's say, bipolar supportive group, or by more education, or even by correct pharmacoprophylaxis, will also show up in imaging. So like Gulaja Saab hinted, what will happen hopefully in next 10 or 20 years is not only cross-sectional imaging studies, but both negative and positively directed monitoring of the changes seen in imaging studies. And that is the exciting part. Never to lose sight of the positive aspects that can be done. I also want to say, Milan, I think the point that you made were great, and for a lot of us too, for our listeners, and I think Shreya possibly might want to come in here more. See, what Milan referred to as lived-in experience is very crucial. He was bingo on when he said that when psychiatrists talk about increasing awareness, there is always that, not fair always, but possible suspicion of there being an axe to grind. When other people who have gone through similar problems and recovered or are handling it, or their family members talk about it, the acceptance is much better. So that's one point. Second, no professional can ever provide the kind of support and bonding that another person with similar problem can. In fact, I'll one more time take the liberty, Shankarji and Kishorji, that at some stage, Hill Foundation, one of the sessions, you might actually want to have on support groups that have come up for cancer care, for mental health care, for autism, for a variety of things. See, what's happening in the health field is that alongside the technical expertise that we may bring in, there is a lot of benefit of lived-in expertise that other people bring in. And only when these two synchronize, if I'm a consumer or a family member, user or a carer, then I benefit. The combined benefit of technical expertise and the lived-in expertise is so much more than even 1 + 1. Gulecha Saab, I've been wanting to add.
Dr. Gulecha wants to add something. Yeah, please go ahead.
Can I speak?
Yeah, please.
Because, there is one thing I would like to make request to all the professionals, that at the first instance, I think it is better not to come to a conclusion that it is bipolar. One can, say, formulate as far as the treatment modality is concerned, but it is the longitudinal follow-up as to what happens after 3 months, after 6 months, and what is the response of it then. Because once the label given, that circulates all over, and any other professional who sees, he sees in the background, which is not justifiable, especially for adolescent group of people. Because schizophrenia is such a condition. Today it will present as a mania, or sometimes as a withdrawn and all, like look to be a depression, and third day it will be a absolute thought disorder in a florid manner. So this is one thing. Second thing is what I am finding in my practice is that we should insist on the physical investigations, especially vitamin B12 and vitamin D. All the others you are all familiar with the system. Because vitamin B12, I am finding many hypovitamin cases of low vitamin B12 deficiency state, both B and by giving them, because so the correction of these two will definitely improve the outcome of the case with the treatment model, whatever case, whether it is schizophrenia or it is a bipolar or. So these are the two my submission to the panel that I think you would accept. Definitely we should not conclude the level, because parents they are very inquisitive. They will ask, "Kya hua hai?" Even in the first instance, you spend only 10 minutes and they want to know, अच्छा आप क्या सोचते हैं, क्या बीमारी है इनको? How can you jump on and give a diagnosis like that? And especially in psychiatry. So professional formulation is a different thing. And as far as the patients and their carer to be told about what is the disorder is a different thing, because that affects the whole lot. And especially in the adolescent group, which are very, say naughty group of people, where you can find that overnight the things changes. Anyway, thank you very much. I will have to leave also. I request the permission of the admin because my OPD is waiting for me.
Please go ahead. I think, but before you leave, I think a very, very valid point that you made, that you cannot straight away jump.
Thank you very much for all the kind words. I appreciate Vani, who has, contributing so many things, and Dr. Shreya, Dr. Milan, and of course R. Shankar, Armin, and Professor Desai. Yes, we will never forget you. You had been a sort of knowledge as a lighthouse.
Thank you very much. I think Dr. Nimesh Desai has always been our opening batsman.
And it's a pleasure to join you again in some other.
Sure, definitely. Thank you very much. Dr. Milan, I would like you to add to what Dr. Golecha said.
That's a little bit of a. I agree that we should take our time to make a diagnosis, etc. But I don't see the idea of not sharing a diagnosis, because that's, I think, something that families get very disturbed about, because not knowing what I'm suffering from yet suffering is very disturbing. So to an extent where patients and families start to feel that even these doctors don't know what they're treating, but they're treating, which isn't a good precedent. Again, we believe very strongly that psychiatry, although a very young field compared to other medical specialties, is still looks to have relatively standardized diagnosis, and for us to sort of have standardized treatments and treatment plans, which we all share across the board, and more or less stay consistent on that. So it's important to discuss diagnosis, prognosis, future, a lot of things, because that is what patients come to us for, right? They very often in psychiatry, we know very well that patients run from doctor to doctor and seek second opinions, third opinions, fourth opinions, which is good, because they get to know more about the illness. So I think that's very important. Without giving them a diagnosis, we cannot psychoeducate them, which is the essence of treatment, right? Because medication is one aspect, but everything else that we do other than medication is what really makes a difference.
Yeah, before I hand over to Kishore, just one small question to you, because I was interested in your bio that was presented. You said that you specialize in anger management. Is acute form of anger a disorder, and how do you treat such patients?
Okay, so absolutely. So when we see isolated episodes of anger, we may find that there may be a lot of underlying possibilities. It could be a disorder in terms of an illness. It could be in a part of a personality disorder. It could be part of depression or anxiety, or it could be just personality traits leading to impulsive behaviors, or so like impulsive group of disorders, maybe originating from an ADHD. So anger may lead up to, anger may be one symptom that may lead up to a multitude of diagnosis. So I think that's the important part. Anger may just be a symptom of something very deep underneath that we have to look for, discover, and sort of manage accordingly.
Is it also genetic? Because normally people say, oh, his grandfather was very angry. I think he has inherited that.
Right. So most neurodevelopmental psychiatric disorders are all genetically passed on. So there is a possibility that, for example, anger and impulsivity in patients with ADHD. Now we know the child has ADHD. The grandfather may also have ADHD, but at that time there was no diagnosis of ADHD. मेरे से ये बहुत मस्तीखोर बच्चा था, पढ़ाई में इतना अच्छा नहीं था, पर बाकी लाइफ में बहुत अच्छा किया. So that could be a description of an ADHD.
Yeah, thank you. Over to you, Kishore. Yeah, Dr.
Can I also say that further to what Milan has said so well, see, not only neurodevelopmental disorders get transmitted, but by now there is good enough research to establish that personality traits, at least susceptibility to personality traits, also will get genetically transmitted. So Shankarji, what you said is somewhat scientifically proven through research on personality traits being genetically transmitted. But the other thing that interested me, as Milan said so well, anger is only a symptom most often. And you need to clinically look for various possible diagnoses. Shreya would agree, in Freudian psychoanalytical terms, depression has been explained as anger internalized and targeted at oneself.
Yeah.
So for those of us who are interested, you might also want to deal with people who are depressed. And frankly, look at our own selves. Forget depression as a syndrome or whatever. Quite often, when you suppress or repress your anger or frustration, you begin to feel low for a variety of reasons, especially because of the anger which is directed inwards. And so that's one useful psychological theory to remember. Can I also plug in here? There is this wonderful panel. I have often in the media, Shankarji and Kishore talked about, and continuing from what I said about anger and introjection. For me, the simplest public education tool is the pressure cooker model of mind. See, if you visualize in the simplest terms psychic apparatus as a pressure cooker, you need to have both. One, the regular mechanism for steam to go out, and of course the whistle to see when the steam is collecting too much. If you don't have either or both of those mechanisms, then you are sure to have a problem. So what's important, to begin with what I said about sharing and sharing being caring, we need to understand that suppressed, or in Freudian terms, repressed negative emotions, including anger, generally don't work out well for one's own mental health. I'll go a step further and say repressed or suppressed negative emotions never work out well even for overall health. To go back to my first few minutes today, let's not even separate physical and mental health. I dare say very, very strongly what research has already found, and so I say that with strength from the research of science, a whole lot of physical health problems, from heart attacks to diabetes, stress-related, to a whole lot of problems, actually occur when negative emotions get internalized and suppressed. And so the expression and sharing of negative emotions is not only useful for good mental health, it's also very useful for good physical health and overall health status. Surely, anger or any other negative emotion will have to be understood how to channelize. I cannot express my anger, and I should not. I try not to express my anger to Shreya's or Vani's discomfort. So I certainly need to respect their comfort and their rights. But in trying to do so and trying to be socially correct, let me not internalize negative emotions, which is the worst thing that can happen. I will
I
keep
thought I just,
repeating the pressure. Yeah, Shreya, please.
no, you can continue. I
No,
interrupted.
please.
Okay, I thought I'd just add to what
I
everyone
want
was
to
saying.
listen to you. Yeah.
Okay. We were earlier talking about diagnosis, and Dr. Millen had said that diagnosis is helpful. I really do think with bipolar disorders, especially, diagnosis is helpful because a lot of times what happens with patients, I just thought I'd collaborate a few points that had been in my head. With patients with bipolar disorder, they don't recognize, and even families don't recognize the manic episodes. They don't, and especially if they have hypomania as episodes that keep arriving, patients don't realize that that is what is happening. So in intervention, what you do with the patient is that you help them understand that there are phases where they do have episodes where they become elated. And with respect to what Dr. Desai was saying, another way of understanding bipolar disorder is that there is a loss which has happened, which you have not been able to recognize. So you deal with the loss. For instance, if I've had a relationship and if I end the relationship, this is a very concrete example. But if I have a relationship and if I end the relationship, there are multiple ways of dealing with it. One way of dealing with it is to deny that I was in a relationship and keep dating other people and make yourself very involved with things, do a lot of things which are very active. You become very elated, you deny it completely. And when you deny that, you feel like everything is, you feel very powerful, you feel very omnipotent. So that's what happens when you're going through a manic episode. What Dr. Desai was saying with respect to anger turned inwards is the depressive end of it. That when you, for instance, have a loss, you're not able to recognize that you feel angry at this person. And what happens instead is that you feel angry, and the loss that you're feeling, you take it in that I am the reason why this person broke up with me. I'm the reason why this person is not there. So often in long-term intervention, we've been speaking about counseling, support groups. Support groups are really helpful because often with chronic disorders, people don't have language to be able to communicate with other people. So forming a community for them is very helpful. And often a long-term intervention where you help the patient recognize their symptoms, recognize also the fact that they have sometimes they deal with losses by denying it completely. They deal with losses by taking in the anger, which turns into depression. All this is in a long-term intervention. That's what therapy would help with. But of course, everyone can add as well.
Excellently put. Excellently
Very
put.
well.
Beautiful.
Can I check with Milan? I'm sorry, Shankarji, I think we are making your job a little difficult, all of us. But allow me, Milan, Bulecha Sahib has had to leave, but you and Vani and Shreya all, would you agree that while I am with you about sharing the diagnosis appropriately and educating, there will be clinical situations, as I tend to do. If a person is in acute mania or severe depression or with schizophrenia symptoms or severe even anxiety symptoms, what I would say to him or her is, look, I have a diagnosis. I know what I am doing. If you don't mind, allow me the judgment to say, when will I sit down and discuss with you? I promise you at some point of time, I'll sit down, discuss with you the diagnosis and implications, but not today. When in my judgment, you are in an appropriate state for us to have a dialogue. So to that extent, I kind of plan the education part, especially with the client who is symptomatic.
Yes, absolutely.
Yeah.
I think yes. So very often we may do that, right? We may at for example, in an acute mania, we may have to, of course, discuss with the family and explain to the family what is happening, so that the family doesn't respond adversely to the patient. And with the patient, of course, we may say that usually in an acute manic phase, the patient is in no mood to listen to your diagnosis at all. So you can definitely defer that discussion. I think it was just to reiterate the point that not giving a diagnosis is not
So
an
what
option.
I think Milan meant was that in principle, a patient is the collaborator. He has the right to know whatever is happening, but of course that doesn't mean that we do tactless communication. Tact is an essential part of our daily this thing. What we say to the patient, how we say to it. I think every psychiatrist or mental health professional has to think on his feet and do it. But at the end of the day, patient is an equal party in whatever we are doing. He's not a mere subject or somebody there. And I agree with Milan that he has the right to know. Now it is the psychiatrist's job to put it in a proper way that he accepts it, understands it, and doesn't feel hurt about it.
Shankarji, sorry, Shreya, what I want Shreya to come in. Shankarji, what Vani has brought up on the table again is another topic for some day, for healthcare, if not including mental health care. From patriarchal relationship of doctors to patients to collaborative relationship.
Yes.
See, that aspect of collaborative decision making is so crucial. Some topics someday. But Shreya, please go on.
Yeah, I was just
I think you have given us so many topics. I think we'll have to work on what to
Sorry, I know.
Yeah, I was just saying that at the end of the day, the diagnosis is supposed to be helpful, but the patient should be able to receive it. So he should be in a state when he can hear it. So I think initially what you're saying, and at the end of the day, when you're working with psychiatric disorders, the psychiatrist has to take the upper hand because they need a psychiatrist to come in. Otherwise, psychotherapy will not work if you're not working with a psychiatrist. So the diagnosis should be given, but I think, it should be received by the patient as well. Otherwise, it's not helpful.
Right. I think I have actually stepped into the time of my co-moderator Kishore Malviya, who is now showing his hand at me, because I said, okay, anger management is very important, so please continue. So I will now hand over to Kishore for his set of questions.
थैंक यू शंकर जी. सब समय कम बचा हुआ है. एक सवाल मैं 2-3 एक्सपर्ट से लेता हूं. मिस श्रेया वर्मा, क्या बचपन में किसी ट्रॉमा की वजह से आगे चलकर बाइपोलर डिसऑर्डर हो सकता है?
I mean, psychoanalytic theory would say this, that but like we have been talking about, there's a genetic predisposition and environmental causes both sometimes work alongside each other. So when you are providing long-term psychotherapy, you would work with the patient to help them understand how their and actually all therapies do this. Cognitive therapies, whenever you formulate anything, you always take the person back to the childhood. You always try to understand what happened in the childhood, because of which your attribution, because of which the way you think is different. So you have to, like we've been talking about, we have to work in a team. There is a genetic predisposition, but environmentally some things may happen which is related to, in a psychoanalytic way, losses, or in a cognitive formulation, things that happen which you internalize, because of which your cognitive, the way you think, there are a lot of distortions. It's the environment which is leading you to have certain defenses and distortions, which you would be actively working with in long-term therapy.
डॉक्टर मिलन, ऐसा क्यों होता है कि लोग वर्षों पुरानी बात भूल जाते हैं, याद रखते हैं और कल की बात भूल जाते हैं? अब मैं अपने मदर के केस में बता रहा हूं कि उनको ये नहीं पता होता कि कल रात को क्या डिनर लिया, लेकिन मेरे बचपन की बातें उनको सारी याद हैं.
जी. ये वाकई में डिमेंशिया का एक कार्डिनल फीचर है शुरुआत में. तो थियरी ये है कि जो मेमोरीज जल्दी बनती है वो जल्दी चली जाती है, जो लंबे समय में हमारे लॉन्ग टर्म सर्किट्स में स्टोर्ड रहती है वो जल्दी नहीं जाती. तो अक्सर ऐसा होता है कि डिमेंशिया के पेशेंट को डॉक्टर के पास इसीलिए नहीं लाया जाता क्योंकि इनको तो सारी बचपन की बातें याद है, पर ये अभी खाना खाने के बाद बोलती है कि मुझे वापस खाना दो. तो ये डिमेंशिया का वाकई में एक कार्डिनल फीचर है, पर बाद में जैसे चीजें प्रोग्रेस होने लगती है तो ये पुराने मेमोरीज भी है धीरे धीरे वाइप आउट होने लगते हैं.
डॉक्टर वानी, आपसे आखिरी सवाल मेरा. मैं अक्सर देखता हूँ, सुबह वॉक करने जाता हूँ पार्क में या सड़क पे भी, कई लोगों को देखता हूँ बैठ के कुछ सोचते रहते हैं, काफी देर तक सोचते हैं, अपने आप से बात करते हैं, ड्राइव करते समय भी सोचते हैं। ये कोई सामान्य फीचर है या किसी बीमारी का संकेत है?
साधारणतः इसको सामान्य ही मान के चले, क्योंकि आजकल ब्लूटूथ वगैरह भी होता है, तो आपको यदि वो इंस्ट्रूमेंट दिखाई ना पड़े, बट ये एक्सेप्शंस अगर आप लेंगे तो बहुत लोग अपने आप से बात करना, या स्पेशली बच्चों में अगर हम देखें तो जब अकेलापन महसूस करते हैं तो इमेजिनरी फ्रेंड्स, इमेजिनरी दोस्तों के साथ बातचीत करना, गप्पे लड़ाना, ये उनकी एक कोपिंग मैकेनिज्म होती है। जब पेशेंट ये जानता है कि वह अपने आप से बात कर रहा है, सामने कोई नहीं है, ये उसकी मन की बात ही है और सामने कोई नहीं है, तो ये बिल्कुल सामान्य बात है। बट अगर पेशेंट बोलता है कि मेरे सामने कोई है जिसके साथ मैं संवाद कर रहा हूँ, बातचीत कर रहा हूँ, और वो व्यक्ति किसी और को नहीं दिखता, तो ही उस लक्षण को हम मानसिक बीमारी की लक्षण समझ सकते हैं।
और अपने आप बैठकर अगर ख्वाब देख रहे हो कि मैं ये बन गया, मैं करोड़पति हो गया और मैं अच्छी अच्छी बातें सोच रहे हो, तो नॉर्मल चीज है।
नॉर्मल है सर, हम तो नॉर्मल बोलेंगे।
भाई मैं ये कहूँ, अगर धीरू भाई ने अपना ख्वाब नहीं देखा होता, है ना, धीरू भाई अंबानी ने जब 60s में ख्वाब देखा, तो जो वाणी कह रही है कि रियलिटी बेस्ड थिंकिंग या बिहेवियर हो, बहुत आउट ऑफ टच विथ रियलिटी है, वो प्रॉब्लम हो जाएगी ना।
नहीं, और मैं एक्चुअली वो जो एडवर्टाइजमेंट एक दिखाते हैं कि आप किसी शैडो की ओर स्टेयर कर रहे हो, ये टाइम वेस्ट है, उसके बदले में आप यूट्यूब में वीडियो देखो, ये गलत है एडवर्टाइजमेंट। क्योंकि ब्रेन को इस तरह का फ्रीनेस, जहाँ पे आप दिन दहाड़े सपने देखो, किसी चीज के ऊपर स्टेयरिंग करते बैठो, ऐसे ही बैठो, ये जो फ्रीडम रहती है ना, इसमें ब्रेन का काम रहता है कि ब्रेन के अंदर की साफ सफाई होती है, ब्रेन के अंदर का रीऑर्गेनाइजेशन होता है, ये हेल्दी बिहेवियर है। कंटिन्यूअसली किसी न किसी मतलब के काम में या सोच में व्यस्त रहना, ये एबनॉर्मल है, इससे ब्रेन बीमार हो जाता है।
थैंक यू मैडम। Over to you, Mr. Shankar.
Thank you, Kishore. Just one last thought before I leave you all, especially starting with Dr. Milan, is I'll take on from what Kishore said, is talking to yourself a key tool to control your anger.
So it can be very helpful in terms of sort of discussing with yourself. We also talk about what Dr. Vani was talking about is almost like a meditative practice, right? Just looking into space, just taking some time to just switch yourself off from everything that you're doing, and that's what we don't do these days, right? We're running from one place to another, or so engrossed in work that there is almost no time for that for yourself, and just to stand and stare and just to sort of introspect and reflect on things that you've done. I think that's something that we all need to consider and look at.
So in the psychological theory, there is also a psychological theory says that what kind of self-talk you have. So if you have an anger problem and the self-talk that you have legitimizes your anger, then your anger problem is going to stay. So a part of the thing which Milan did not mention is also that there are some people who use anger as a learned behavior to get an advantage of the society. Now the psychiatrist has an unenviable task to tell him that this is not, there are other ways to get things done. Don't get outburst is not a legitimate way. So the self-talk is a very, very important. What you tell yourself as what goes and what doesn't. So that does determine your mental health.
Thank you very much. I think it was a wonderful session, as what Dr. Milan just tweeted, a message rather in the chat, that this was a fabulous session that we had so far. And my special thanks to all the panelists, especially Dr. Nimesh Desai, who stayed on right from the beginning to the end. And I'm sure we're going to have him more. And he added so much of spice and made my job easy, because questions that I was supposed to ask, he asked. So thank you very much, Dr. Nimesh Desai. I think you added much value. Thank you, Dr. Shreya, thank you, Dr. Vani, and thank you especially Dr. Milan for making this so lively and wonderful and make us understand who we are. Thank you very much.
Thank you, sir.
Thank you.
Thank you,
sir.
Thank
Good
you,
Sunday,
everybody.
sir.
Yeah.
Bye-bye.
Bye.
We will now move on to the quiz. First quiz. Well, which of the following statements concerning bipolar disorder is correct? A, bipolar people cannot hold steady jobs. B, in addition to medication, there are other effective treatments for bipolar disorders, including diet, exercise, proper sleep, and physiotherapy. Bipolar disorder can only affect adults. D, none of the above. I'll give the answers immediately. Well, the answer to the quiz is that in addition to medication, what is the statement concerned? Which of the following statement concerning bipolar disorder is correct? It is B. In addition to medication, there are other effective treatments for bipolar disorder, including diet, exercise, proper sleep, and physiotherapy. Thank you very much. I now hand it over to my co-host, Kishore Malviya.
थैंक यू सर, थैंक यू। तो आज के एपिसोड में इतना ही। हमें उम्मीद है कि तमाम विशेषज्ञों के विचार से आपको फायदा होगा और अब आप मानसिक समस्याओं को हल्के में नहीं लेंगे। सभी विशेषज्ञों और दर्शकों का आभार व्यक्त करते हुए हम आज का एपिसोड समाप्त करने की इजाजत चाहते हैं। अगले रविवार को फिर मिलेंगे सुबह 8 बजे यूट्यूब और फेसबुक पर लाइव और चर्चा करेंगे कोविड के फिर से सिर उठाने की संभावना पर। अगर ऐसा हुआ तो भारत अभी कहाँ